कितने बजे है मीरा?
उनका भी 5 o'clock है।
अच्छा अच्छा,
वो चीफ गेस्ट के लिए रुकते मैडम, उनको आदत है चीफ गेस्ट के लिए रुकने की।
डॉक्टर नहीं, आई जस्ट डोंट वांट टू शो ऑफ।
नहीं तो मोनिका मीरा को पहले बोल ले तो चले जाते।
ऐसे करते हैं मंदाकिनी नहीं, उषा जी को जो जिसका है उसको डिस्टर्ब नहीं करिए।
नहीं यार, अगर तुझे जाना है
आप इफ यू वेरी काइंडली परमिट, मैं उधर शक्ल दिखा के फिर इधर आ जाऊं, जो बताइए आप।
हाँ,
यहाँ पहले
यहाँ दादा देर रुक जाएंगे,
फिर बिना बोले तो आ नहीं पाओगी
जी। नहीं वो फोन उनका आ रहा है।
तो ठीक है, कोई बात नहीं
मैम,
तुम ऐसे कर लो।
मैं यहाँ पे स्टार्ट कर देती हूँ। आप मैडम आपको इंट्रोड्यूस कर लेते हैं।
तुम हो आओ मीरा, हो आओ। हाँ हो आओ मीरा।
मंदाकिनी
हाँ बोलिए।
A very warm welcome to all the esteemed faculties, the chief guest, Dr. Usha Sharma ma'am, Dr. Meera Agnihotri madam, Dr. Chandravati ma'am, and Dr. Manjushla ma'am. We are here to host the 13th episode of the Gyanganga Widwatta series, which is the brainchild of Dr. Mandakini Meg madam. This was done in order to disseminate the knowledge that was to every nook and corner of this country, so that each and every obstetrician gets benefited by the practical knowledge. That is why this webinar series was started. Ma'am, I am extremely privileged to invite you for an e-inauguration of this webinar. Can we have the slide on cursor? The inauguration slide, please. And please place the Saraswati Vandana. So there's no audio.
नहीं हो रहा।
I also take privilege and the honor to introduce Dr. Mandakini Meg madam. She is the chief director and convener of this series. Madam has been the past chairperson of ICOG, and she is the national president of AMWI. We welcome you, ma'am, and I request you to please carry forward the inauguration session by introduction of our chief guest. Can we have Dr. Usha Sharma ma'am's slide, please, Amit?
Yeah, sure. We can play it this time. There will be sound.
Yes.
Okay. Play it.
There's no voice, ma'am. It must be some internet issue.
आवाज नहीं है।
नहीं, बहुत connectivity poor हो रही है ना सब दूर। No problem. I think we should.
No problem. You can go ahead. I think.
Yeah, I think inauguration is already done because of the presence of our all dignitaries, and it's a great privilege, madam, to introduce you. But before that, I want to say that all the seniors like Dr. Usha Sharma madam, Dr. Meera Agnihotri, Chandravati madam, have been all the time blessing me. I think we have association of more than 40 years. और उषा शर्मा मैडम हमेशा मैं आपके यहाँ पर आती रहती हूँ, हमेशा. And I am invited for all their UP COG and I am one of the UP person only. तो मुझे लगता है कि आप लोगों के ब्लेसिंग से मैं बहुत मतलब आपको धन्यवाद देती हूँ. और ये ज्ञान गंगा सीरीज जो शुरू की थी, जो कि गंगा है, आप लोगों की ही गंगा है, यूपी वालों की गंगा है. तो दिस आइडिया वाज स्ट्रक व्हेन मी मोनिका वी वर ब्रेनस्टॉर्मिंग कि किस तरह का स्टैंडर्ड प्रोग्राम किया जाए. वो जो प्रोग्राम जो मैंने आईसीयूजे में किया उसी स्टैंडर्ड के प्रोग्राम होना चाहिए. उसके बाद में वी हैव टेकन द स्टेट वाइज, लाइक सपोज आई हैव डन आंध्रा विद आंध्रा में देयर वर इंक्रीज रेट ऑफ सिजेरियन सेक्शन, तो वी टच्ड अपॉन दैट सब्जेक्ट. other places there was GTN, tropoplastic neoplastic tumor, that I had. So all over India we have done with the states. UP we kept special month for July because we really wanted all your attention in this particular month, and we are going with this wonderful scientific program. So this was the idea, and I think everybody came together, and we have more than 4,500 viewership, and the recordings are also going. They are taking the recording also, and we have a wonderful speaker. And with this Gyanganga series going on so strong, and each and every person is, collaborating with us. Just now, Dr. Meera, Madam has said कि ICOG standard, मैं उसी standard से हर program करना चाहती हूँ, और उसी standard के सारे scientific speakers, everybody, is they are participating. So today also we have galaxy of speakers and panelists, etc. And I wish to thank everyone who was around in this journey of Gyanganga. So with this, I take the opportunity to introduce. I know nobody, there is nobody that who doesn't know the Usha Sharma Madam, our legendary Padma Shri Dr. Usha Sharma Madam. She was I was a director in Maharashtra. Madam, मैं आपसे बहुत correlate करती हूँ क्योंकि आपका मेरा teaching and everything is similar. Administrative line पे जाता है. So she was the ex-director general of medical education of Uttar Pradesh. Very, very important. And you must be nowadays reading so much curriculum is being changed of the medical education. ये हो रहा है, drastic changes are being done. Then she was a principal cum professor of gynec and obstetric at the Medical College Meerut. Lifetime Achievement Award, UP chapter OBGYN, patron of Meerut OBGYN Society.
Most ख्याल में मंदाकिनी, I think क्यों इस पे टाइम खराब करो?
नहीं मैडम, दो तीन काम की बता रही हूँ. So पद्मश्री बहुत कम लोगों को हमारे मिले हैं. इसमें से gynecologist हैं, everybody knows Alka Kripalani, this everybody, but the madam was the pioneer. बहुत कम लोगों को, डॉक्टर लोगों को पद्मश्री मिलती थी उस जमाने. BC Rai Award, and all those awarded, the distinction. I think, madam, it's up to you. We take, inspiration from you. And what I personally feel, जब भी मैं आपके साथ किसी भी स्टेज पे या किसी भी समारंभ में होती हूँ, आपके बोलने का तरीका, आपको कंक्लूड करने का तरीका, you take everybody's names, and I don't know how, it's a fantastic, madam. I'm really inspired. मैं भी कोशिश करती हूँ आपके जैसे बनने की, पर थोड़ी कम पढ़ती हूँ. So no problem, madam. So with this, I think we should give a big hand to first only, madam. हम आपको आपके लिए स्वागत और तालियां बजाना चाहते हैं. And thank you for, decorating and, being a distinguished chief guest for our program. So, madam, please bless us with your blessing, and also for my election, let me be little frank for my election also, because you know what kind of work I have done in government, in POXI, and in ICOG. So, madam, floor is yours.
Thank you very much, my dear Mandakini. Everybody knows Mandakini, how much she has contributed to each and every organization where she was. I can tell you that not only her contribution, but she is a very loving, affectionate, and a lovely person. You never feel that she is a chairperson of ICOG or she is holding such a high post. Mandakini, may God bless you success in every step of your life. And I am sure that you will get success. And even Kanchan हाथ जोड़ रही है बैठ के. Kanchan,
thank you, madam.
All very best. I am not seeing Dr. Chandravati with me.
No,
but
so
Mandakini, Dr. Chandravati, Dr. Meera Agnihotri, these two persons are like pillars of UPCOG and have always supported me like anything. And then Manju Shukla, अभी तक उसने join नहीं किया है, नहीं तो वो सबसे पहले कहती, और मैं भी तो. And really, she is such a person who is always ready to help everyone. And then today we have two very, very learned speakers. First is Mandakini, of course, who will be telling us about the management of preterm labor. And then we have Dr. S.P. Jaiswar. She is really very hardworking. I know her for the last so many years. हालांकि मंदाकिनी को बहुत पहले से जानती हूँ, but S.P. Jaiswar को भी मैं around a decade बहुत अच्छी तरह जानती हूँ, and she is also very hardworking. She will be speaking on etiopathogenesis of preterm labor. And the first session, as I will be chaired by Dr. Kanchan Sharma and Dr. Rashmi Vyas, and Mandakini's lecture will be chaired by Dr. Alka Sethi as well as Dr. Kanchan Prasad. And apart from that, we have got a very good panel discussion on decision dilemma of preterm labor, because really it's a very, very, I can say it's a great dilemma for all of us. And to come to the conclusion what to do and what not to do is very, very tricky. And that panel discussion will be moderated by Sanchita, as well as Rena, I think, and Rena. And all the learned panelists. It really gives me a great pleasure to be with you all on the occasion of this webinar under the auspices of Gyanganga Widwatta series, which is, I can say, is a baby project of Dr. Mandakini Meg. And I am following this project from its inception. And I really tell you that it's a project where you have the training and learning of many very, very difficult subjects, which are very important and needed in our day-to-day practice. I will always like to appreciate, admire, and congratulate Dr. Mandakini Meg for starting this series, which will be very beneficial for every one of us. Now, as you all know, that preterm labor is a labor before 37 weeks of pregnancy. And the babies who are born little too early or too soon, they become quite weak and are susceptible to many diseases in the near future. As estimated in 2023, there were 13.4 million of babies who were born early date or who were born prematurely. And out of those 13.4 million, 90,000 babies died. And many babies who survived were having lifetime disabilities like learning disabilities, like visual problems, as well as the hearing problems. And these days, you will agree with me, the busiest part of any multi-specialty hospital is NICU. हमेशा भरा रहता है because of these problems. And then despite the increased access to the antenatal care in public as well as in private sector, we have not been able to decrease the incidence of preterm labor, which is a matter of great concern. And we know that as regards the etiopathogenesis, it's not clear at all. Though we have usually seen that it occurs as a consequence of intrauterine infection or chorioamnionitis, but even then, exactly you can't say what is the etiopathogenesis. And so we have to do more researches, more studies, more discussions to determine the cause, mechanism, as well as the prediction of preterm labor. I am sure that Mandakini has planned such a wonderful program today on preterm labor and preterm birth that it will go a long, this deliberation of this program will go a long way in updating the knowledge of every one of us. And really, Mandakini, the subject you have kept, they will really enlighten us to know about the prediction of and causes and management of preterm labor. And I am sure that with this knowledge, we will be able to do something. At least we can reduce the global burden of preterm birth, which is a matter of great concern. With these words, I wish this program a great success. And Mandakini, thank you very much for making me a part of such a prestigious program. And I wish you all the best. I wish even Kanchan all the best. SP Jeswar, now I can see you. I know she is a wonderful orator, and every one of you will have a very, very good academic feast. Thank you all very much and wish you all a very happy, healthy, and bright future. Thank you.
Thank you, Usha Sharma, madam, for those very, very inspiring, very warm, cordial, and lovely words, I can say. Because ये हमेशा heart को touch होता है, and those are the words are very sincere. That is what is a main thing which we feel. And thank you for wishing me all your blessings and wishes. With this, I think we are moving forward Dr. Meera Agnihotri madam is not there.
वो तो शायद थोड़ी देर से आएगी।
हाँ,
हाँ।
थोड़ी देर से आने वाली है।
चंद्रा जी भी नहीं दिख रही हैं?
नहीं, चंद्रा जी आज थोड़ा बिजी है, उन्होंने हमारे ब्लेसिंग्स दिए हैं। I can, on behalf of Dr. Chandravati, I can say that she told me that Mandakini, please, for blessings from my side, and also she is wishing everybody a very great program. She wanted to be here, she said consented. Madam has come kya? Monica, नहीं.
Ma'am, not yet.
गुड इवनिंग मैडम, नमस्कार आप सभी को।
आ
गई मीरा, आ गई। मीरा अनम्यूट कर।
Yeah, so now
अनम्यूट कर मीरा। और
now our another chief guest is Dr. Dr. Meera Agnihotri, who is again a great legend of the and the pillar, as Usha Sharma madam has said, of the UP COP. I cannot imagine UP without Meera Agnihotri madam and Usha Sharma and of course Chandravati madam. And I think it's a great privilege. जब मैं ICUG चेयरपर्सन बनी मीरा मैडम, तो सबसे पहले मुझे आपका ख्याल आया। आपका ख्याल इसलिए आया कि who are the founders of FICUG? और उषा सरैया मैडम बोले कितना सुंदर थॉट है। थॉट itself is beautiful. Awards are later on, है ना? And then we conceived the idea of giving all the founders of ICUG the ICUG Ratna Award, which was very aptly nominated or suggested by Meera madam only, कि you call it a Ratna Award because they are the really legends of ICUG who has really founded. तो मैडम थैंक यू वेरी मच फॉर एवरीथिंग। आपने मेरा फाउंडेशन इतना सुंदर डाल दिया कि मैं उसके ऊपर काफी काम, वो कहते हैं ना, राम नाम का ब्रिज बन गया। हम लोगों ने पूरा ब्रिज क्रॉस कर लिया, अभी लंका पहुंच गए लंका दहन करने के लिए।
देखो मैंने पीछे लगा रखा है।
मैंने देखा, मैं हमेशा ऑब्जर्व करती हूँ कि आपको जो विद्या विभूषण अवार्ड दिया है वो आपने पीछे लगाया हुआ है। सो थैंक यू वेरी मच। सो इट्स अ ग्रेट प्लेजर मीरा मैडम टू वेलकम यू टू दिस वेरी प्रेस्टिजियस, आपके कानपुर की गंगा है और ये गंगा, ये जो हमारा ज्ञान गंगा है उसी से इसका उद्गम होता है। और ज्ञान गंगा सीरीज हैज बीन गोइंग ऑन वेरी स्ट्रॉन्ग। 13th एपिसोड चल रहा है and we have touched upon all the subjects, all the luminaries were our faculties, and wonderful state wise we are going. Last time we were at the Telangana, then we were at the Gujarat, so it is very appreciated. We have viewership of around 5,000 people. So to introduce our dear Meera madam, she is a foster family. I can say she is my family. पहली बात तो वो हमारी family member है। बाद में now she is a professor and head of the gynec department of the Kanpur medical college, very prestigious, and I think is one of the oldest medical college. Chairman of ethics and research committee of medical cell. She is a president of very famous WWW, that is women empowerment. Whenever word women empowerment comes, I only think of Meera madam, and she keeps me inviting for all my domestic violence and the specialization which I carry in the gender violence, etc. She always involves me. Then represented India in Foxy National AIDS in Montreal and Canada, organized international WW conference.
That is okay. Mandakini, it's okay.
Madam, 1 minute. That time the President of India was the honorary, the chief guest, and it was our privilege to meet the President of India because of you. There are so many awards and positions and so much of this thing. And most important comment which I think everybody should know here is from her son-in-law. So उनके son-in-law ने एक दिन मुझे कहा, मैंने बोला आपको कैसे लगता है surrounded by so many dignified dignitaries, women, doctors in your family? तो बोले heads up to them, इतने ऊंचे लेवल के लोग मैंने कहीं देखे नहीं। मैंने बोला आपकी मदर इन लॉ, आपकी वाइफ, how can you cope up with so many women, so intelligent women, and you yourself IAS officer? संजय की बात कर रहे हैं। So he came out. I always tell my husband, who is also IAS officer, उनसे कुछ सीखिए, कितना रिस्पेक्ट करते हैं, womenhood का कितना रिस्पेक्ट और इंटेलिजेंस का कितना रिस्पेक्ट है। So madam, thank you very much for being in my life and always you will be there for me. आप मुझे भूलना मत 1 अगस्त को, With this, I think I'm inviting you for the floor is yours, madam. Please bless us with your,
आपकी मैडम ने
मंदाकिनी
WWCon ऑर्गेनाइज करवाया, बिल्कुल
हेलो
बहुत बढ़िया।
मंदाकिनी
Kanchan Jara.
at the outset I am humbled but really honored to be a part of this great meeting where my right and left are three legends, Usha ji on one side and Chandra ji on the other side. And actually, when two legends are on my side, I have always become stronger. You have got a strong pillar on either side, you really become stronger.
Meera, rather I said, I don't think there is any existence of my without Meera and Chandra ji. Great pillars in my life.
Thank you. Thank you, Usha ji. So, Mandakini, we all three are for you. And I will like to just rate few words about Mandakini. She is not only a very pleasant, simple, humble, down-to-earth person, but you can discuss anything with her, just like a family member. And Usha ji, in last 2-3 decades, I think women violence with domestic violence, physical violence, and then sexual violence, we have had very many topics on international and national platforms, and Mandakini was a part of it, and we have really enjoyed it. We have discussed it. बहुत सी तैयारी कर करके हम लोग जाते थे ऐसे लड़ाई करने जा रहे हैं for women empowerment and so on. And her tenure as ICOG chair was admired by everybody. All of us have admired. And the things which she has done, you see, founder fellows, the only 5, 6, 7 founder fellows who were asked by Dr. Soniwala and at that time Dr. Usha Saraiya and so on. So UP में से मीरा तुमको बनना है like that, and we just entered, or whatever we were advised, we kept on doing it. क्योंकि 1995 में मुझे national conference करनी थी, तो I have to do whatever they were telling, and thereafter I realized that the academic wing is one of the most important wings of our Foxy, and we have done a lot of in it. And at the end of the day, I must say it is not the end of the day, but whatever we could get, this ICOG Ratna Samman is one of the highest Samman which I have received from Foxy, and I will always be indebted to our Foxy and ICOG chair for giving me such a big Samman with all the foreign dignitaries and whatnot. When I was asked to talk, to taste something, I was just speechless. What to say, how to thank, and when to thank, and what to thank. So it's like this. So Mandakini, you have really created history in the academic wing, and I'm also thankful that you admire Sanjay, because Bombay only, Usha ji, I want to inform you, Bombay people have invited Sanjay, and in Bombay, when probably Suchitra Pandit was president, and he was honored for the organ donation. उनको कंट्री में ऑर्गन डोनेशन का बहुत बड़ा सम्मान मिला हुआ है. हमारे मनमोहन सिंह जी ने वो सम्मान उनको दिया था. So he was invited by Foxy, and this सम्मान was given to him. I thank you, Mandakini, for remembering it and talking about it. Now coming to the subject, I welcome your academic series like anything. You are an academician par excellence, and I know that the subject chosen by you, they will be multifactorial, and you will get a lot of opinions from persons around it. And everybody sitting, I can see Dr. S.P. Jeswar, I can see Rashmi, I can see Kanchan, and Usha ji. I believe Chandra ji could not join. Anyhow, so it will be a just wonderful meeting. Mandakini, I just endorse all your endeavors with full heart.
Thank you. Thank you.
And on behalf of Usha ji also, I commit that we are all with you. So this is our joint venture to make a commitment from all of us for being with you. And it's really an honor to share the dais with the great persons sitting over here. Thank you very much once again, and best of luck for this series again. Thank you very much.
Thank you. Thank
you. मीरा जी, आपने जो कह दिया वो it is engraved in my heart. always. And second thing, I just forgot, madam, Usha Sharma, मुझे माफ करिएगा, आपका ये पद्म विभूषण, पद्मश्री के बाद विद्या विभूषण जो अवार्ड है, ये ICO जी ने आपको प्रदान किया हुआ है.
Exactly. मैंने कहा मैंने लगा रखा है.
वही मतलब मैडम ने जब बोला ना कि विद्या, इनका जो रत्न अवार्ड था, आपका भी विद्या विभूषण. तो और तीसरा राज बवेचा मैडम, मतलब यूपी के उस समय स्टेज पे 3 लोगों को इतना बड़ा सम्मान एट ए टाइम, 3 लोगों को मैडम, मुंबई के नहीं थे, यूपी के ज्यादा थे. आप प्लीज ग्रहण करिए मेरे शब्दों को कि मैं क्या कहना चाहती हूँ. आप लोगों ने वैसे फाउंडर जैसे काम किया है और मैंने आपके काम को पहचाना है, आइडेंटिफाई करके इमीडिएटली उसको कन्वर्ट किया है. सो मैडम थैंक यू वेरी मच एंड आई थिंक इट्स अ ग्रेट रिलीफ टुडे. आज मुझे बहुत अच्छी नींद आने वाली है. यू विथ मी, यू आर रीअश्योरिंग मी, and though I was knowing it in the heart, but I think with your blessings, 100% with Gyanganga like this, we are going to fly, coming in very good position. और मैडम मैं आपको एक प्रॉमिस करना चाहती हूँ on this platform that 14 जून को मैंने GR निकाला. संजय गुप्ता ने मुझे 7 months पहले कहा कि we are all troubled, ऐसे ऑब्स्टेकल, तो कोई तो ऐसा व्यक्ति होगा जो हमें मदद करेगा. तो मैडम मैंने वो फाइल लेके मैं सिर्फ 2 मिनट आपका लेना चाहती हूँ. फाइल मैंने ली, मैंने वहां पे डायरेक्टर, बिकॉज आई वाज अ डायरेक्टर ऑफ हेल्थ, तो मुझे सब जानते हैं, आई हैव गॉट अ वेरी गुड रेपुटेशन, तो मेरी बात भी मानते हैं. तो उन्होंने फटाफट प्रोजेक्ट बनाया, मिनिस्टर के बाद प्रिंसिपल सेक्रेटरी, फिर मिनिस्टर, यू नो हाउ इट इज. GR निकालने के लिए ये सारी स्टेजेस होती है. मैंने हर लेवल पे फॉलो किया, हर लेवल पे. 7 महीने के बाद मैडम GR निकाला और अभी उसमें एट ए टाइम हमारे जितने भी ART इनफर्टिलिटी सेंटर से सबको रजिस्ट्रेशन मिल गया. दैट इज ए रियल वर्क ऑफ ए लीडर मैडम. ये नहीं कि मैं यहाँ गई वहां गई ये किया. सी दिस इज अ रियल वर्क. मेरे यहाँ पे लोग बैठे हुए हैं, आशा सिटी है, बहुत सारे लोग हैं जिन्होंने मेरी वजह से FICOG लिया. मैडम आई हैव टेकन FICOG देयर हाउसेस. फॉर्म भरना नहीं आता था, FICOG करना नहीं आता था, दैट ऑल्सो इन्हें हैंड होल्डिंग किया. तो कहने का तात्पर्य है कि मैडम मैं अपने लिए नहीं कह रही हूँ, सबके लिए. आप लोग जो यूपी के मासेस हैं, हम लोगों को लीडर कौन चाहिए जो आपको आधी रात को उठ के आप उनके साथ में गवर्नमेंट में जा सके, आप अपनी बात रख सके, आपका ट्रबल कम हो सके. ये इसके लिए खास करके हम लोगों को नॉलेज तो ठीक है मैडम, नॉलेज तो आप बड़े बड़े प्रोफेसर लोग हैं, नॉलेज तो हम लोग दे ही लेंगे, ले भी लेंगे, परंतु लीडर ऐसा होना चाहिए कि जो आपके कंधे से कंधा मिला के आपको आधी रात को आपको लगे उसके बारे में कंफर्टेबल कि नहीं. उषा शर्मा मैडम है, नहीं मीरा अग्नि, नहीं मंदाकिनी मैं गया, जिसको आधी रात को परसों एक लड़की का उन्होंने टर्न डाउन कर दिया, PCP सरोगेसी, रोने लगी. लड़की का नाम अदिति है, बम्बई में. कल मैडम उसका रजिस्ट्रेशन मिल गया. मैंने अथॉरिटी को बोला अंडर व्हाट रूल यू हैव टर्न्ड आउट. मैडम कल मिल गया. अभी आज वो सब दूर लिख रही है कि यंग गायनेकोलॉजिस्ट को अगर प्रैक्टिस करने में कोई मदद, बम्बई की बात करें मैडम, तो कोई मदद करता है तो मैडम ने हमको आधी रात को सब लोगों से लड़ाई करके हम लोगों. सो व्हाट आई एम सेइंग नाउ, आई कंक्लूड. सो दिस काइंड ऑफ थिंग आई एम ट्राइंग टू डू व्हेन आई बिकम द कम इन द पावर. सो विद दिस आई थिंक मैंने बहुत समय ले लिया आपका. थैंक यू वेरी मच मैडम. And now we progress with the program.
It is a pleasure to listen to you, Mandakini.
Thank you.
Love and blessings.
बस थोड़ा मंदाकिनी, आई एम सॉरी, मुझे भी थोड़ा जाना है, क्या बताऊं, कभी कभी ऐसा हो जाता है, बट आई विल ट्राई टू कम बैक अगेन.
नहीं मैडम प्लीज आप अपने हिसाब. Thank you very much.
Ma'am, we were honored to have you and Meera ma'am with us. Having you on this platform, it means much more to me and Mandakini ma'am. Thank you so much for your gracious presence. And Chandravati ma'am also wanted to join in, but she had her prior commitments. And Manju madam is not feeling well, but she has sent her best wishes for the program. We now continue with the academic session. This session is by a talk by none other than Dr. S.P. Jaiswal ma'am. Can I request to have the slides of the chairperson, please? Dr. Rashmi Vyas ma'am is a faculty of the ICOG. She's an ex-executive council member, Society of Fetal Medicine UP chapter. She is the ex-president of the Noida OBGYN Society, the organizing chairperson of the North Zone Yuva Foxy 19, the ex-consultant at OBGYN Ministry of Health, Sultanate of Oman. Received appreciation award from Foxy for her exemplary work, and she has published various articles and received many awards and been invited as a faculty in national and international conferences. She has also received the Appreciation Award for exemplary work during the Bhopal gas tragedy in 1983. And she's a member of almost all the associations that are present in India, ma'am. We welcome you, ma'am. Our next chairperson is none other than Dr. Kanchan Sharma, ma'am. She is the director and the chief consultant of Akash IVF Center, Kanpur. She has been the secretary of Kanpur OBGY Society in the year 21-23. And she is the president of IHRF Kanpur. She is an ART specialist, a laparoscopic surgeon, and a colposcopic surgeon as well. She is currently the candidate for chairperson NCT Committee Foxy. And madam, we all support you. She has had her trainings in ART and embryo handling from Netherlands and from the Rainbow IVF Center, Agra. She has an operative laparoscopic training from Mumbai, France, and ultrasound and fetal medicine from AIIMS, Delhi.
Thank you.
She has been given the Foxy Achievers Award, the Pratigya Social Impact Award, the Empowerment Women Award, the Hari Ratna Samman, the Corona Warrior Award. To name it, ma'am, the list is endless. We welcome both of you to please chair this session and introduce our speaker, Dr. Jaiswal, ma'am.
Thank you very much. First of all, my sincere thanks and regards to my teachers, teacher of teachers, and most respectable Dr. Meera madam and Dr. Usha Sharma madam, and Dr. Chandravati madam is not there. Dr. Meera madam always is with me in Kanpur and always blessed. Dr. Usha Sharma madam, you are also a family member of even Kanpur. We think you that you are of the Kanpur and always blessed by your nice words. And my regards and thanks to Dr. Mandakini Meg madam. Today's speaker, madam, you have chosen very good topics, and we all wish you for your future endeavor, and also say for my NCT committee chairperson support. Today's speaker is Dr. Shyam Pyari Jaiswal. She is the president of Lucknow Locks at present. She is the professor and head of Department of Obstetric Gynae, KG Medical College, Lucknow. Madam, you have got so many awards. Narki Fest Award 2014, Jagdishwari Mishra Award, Silver Jubilee Trophy Award, CS Dawn Prize Award, Best Published Paper Prize of the Jogi, and many social awards are in your feather. You have done so many publications, and whenever I meet, you are a very good at heart. So floor is yours, madam. You are invited for your talk.
Thank
Welcome.
you so much, Dr. Kanchan. Thank you so much. First, I would quite grateful of Dr. Mandakini, who has chosen me for this lecture, along with my teacher, Dr. Chandravati, Dr. Meera Agriti, Dr. Usha Sharma. All of them are a guru and the backbone of UP. Am I pronounced to all of you? And Manjuji, although these people are busy in somewhere else. So should I start my lecture?
Please.
And
Yes,
my best wishes to Dr. Mandakini and Kanchan also for their great success. Thank you so much. So I'm going to share my presentation.
Hello, Sanchita. Welcome. Asha Sethi, Alka Sethi, welcome.
सूर्या आके जरा शेयर करो.
डॉक्टर अलका सेठी, आपका नाम डॉक्टर मीरा अग्निहोत्री लिखा हुआ है.
सूर्या,
till she starts, I just want to thank you to Dr. Mandakini Meg madam for giving me this opportunity to join at this platform where all legions are there. And my sincere regards to all the legions. And just few words about Dr. Mandakini Meg madam. Great leader, great visionary, though Dr. Usha Sharma madam and Dr. Meera madam have said everything, but still, she is a great leader, great Foxian, and ICOG tenure, she has showed her capabilities. Everyone, even me, she is a friend, philosopher and guide.
Is that now I'm sharing? Please see it. Is that sharing?
Yes,
I-
madam. Yes,
And
madam.
it's
Yes,
moving
ma'am. Can you
also?
make it full screen?
I'll
Can
say
you make
one
it
thing.
full screen, ma'am?
Foxy
Full
deserves Madam as a
Surya,
president.
यहाँ full
actually.
screen करो.
थैंक यू उसमें बाद में
Dr.
बोल देना,
Monica.
एक बार और बोल देना बाद में.
Dr. Monica,
इधर full screen दिख रहा होगा.
Dr.
Yes, ma'am.
Monica, this is Dr. Sanchita. Can you please send the link on mail? Actually, मेरे लैपटॉप से खुल नहीं रहा है मेल के
Ma'am,
बिना.
can you just send me your email ID on WhatsApp? I will do the.
मैंने आपको व्हाट्सएप किया है, मैं फिर से कर देती हूँ.
Yes. Okay, ma'am. No problem.
ओके, आप मेल पे भेज दीजिए so that I can open it because वो प्रेजेंटेशन नहीं खुल पाएगा फिर.
भी शेयर किया था ना.
मैंने मेल भेजा हुआ है डॉक्टर मोनिका आपको.
हाँ, I'll just take it, ma'am.
श्योर.
Yes, ma'am.
मैं शेयर करती हूँ संचिता, मेरे पास भी है आपकी मेल, मैं भी कर दूंगी.
अच्छा, मेल कर दीजिए आप. हाँ,
हाँ.
क्योंकि मैं अभी मोबाइल से कनेक्ट हो पाई हूँ.
No, I'll do that.
ओके.
Madam, this is okay, but make it full screen.
फुल स्क्रीन करिए ना नीचे जाके. हाँ बस है.
हाँ, Dr. Kanchan, it is okay?
Madam,
नहीं, अभी
full
वो
screen नहीं हो रहा. Full screen नहीं है.
ये हमारे उस पे हो रहा है और आपके पे नहीं हो रहा है.
आपने full screen वाला बटन दबाइए मैडम. ये
हाँ, वो दबाया है, but I don't know why it is not. But on my screen it is showing full screen.
Please change the slide. Then we will see. Change the slide.
संचिता देखो आ गया होगा.
हाँ.
ये resume का बटन आ रहा है ना. Resume slide show.
Resume slide.
ऊपर लिखा हुआ आ रहा है.
नीचे जाके आप फुल स्क्रीन कर सकते हो. हाँ अभी.
Ma'am, बस करिए. You can still start presenting. तब तक वो हो जाएगा, ma'am. You can ask somebody else to do it for you.
मैडम ऊपर जो होम इंसर्ट डिजाइन एनिमेशन के नीचे स्लाइड शो है, वहीं पे स्लाइड शो हो जाता है.
Ma'am, you're using the lower version of the PowerPoint.
Yes.
When
Dr. Rashmi, thank you.
Now
Got the
see?
mail.
Okay.
This is full screen.
Okay. It's not, ma'am. You need to share it again. Please click on share screen, the green share screen button. Down. So once you click on, ma'am, please wait. I'll stop it again for you. Okay. So once you click on share screen, a small pop-up will open. On that, you have to select the first option from the lower side, upper side, upper, lower, left side, first option, screen or desktop.
But it shows full screen on my desktop. I don't know
Yes,
why.
ma'am. I agree because it is the lower version of the PowerPoint.
नहीं, आप एक बार क्लोज कर दीजिए और फिर
बंद कर दो,
पहले
फिर से start
शेयर
करो.
करिए और फिर करिए स्टार्ट.
So ma'am, once you click on share screen,
Hmm.
please click on the left upper option, the screen, entire screen or desktop.
इस पे तो हमेशा करती है ना. शी इज ऑल द टाइम. ऊपर टॉप पे लेफ्ट साइड में. कुठे करायचं.
Ma'am, when she selects that time, she has to do it.
अच्छा.
Ma'am, what you do is you first open the PPT on your desktop and make it slideshow, and then you start sharing your screen. You will be able to see the full screen. In the meantime, ma'am, you can start talking also, ma'am.
हो रहा है कि नहीं मोनिका. ये तो मेल लेके बुला लो ना हमारे तरफ. हो गया. ऊपर.
Let it be like this only, ma'am. You start speaking in the meantime.
Okay.
ठीक है, ऐसे ही रहने दीजिए मैम, चलेगा। चेंज टू सेकंड स्लाइड।
हेलो मैडम, आ रहा नहीं आ रहा अभी भी?
मैडम ठीक है, जो भी आ रहा है, सेकंड स्लाइड करिए,
slide
चेंज करिए।
आप स्लाइड दिख रहा है मैम, आप प्रेजेंट करना शुरू कर सकते हो।
हाँ डॉक्टर कंचन, नहीं आ रहा है?
मैडम दिख रहा है लेकिन फुल स्लाइड नहीं आ रही, फुल स्क्रीन नहीं आ
हमारे
रहा है।
फुल स्क्रीन शो कर रहा है, आपके उस पर डेस्कटॉप उधर नहीं आ रहा है। ये समझ
नहीं तो
नहीं आया, क्या मैं
देखिए
दूसरे लैपटॉप से अटैच करूँ क्या?
चलेगा मैडम, चलेगा, कोई बात नहीं है, इसी को दूसरा करिए, सेकंड स्लाइड करिए।
आई एम ट्राइंग टू डू इट, पर वो फुल स्क्रीन में आ नहीं रहा है।
कोई बात नहीं।
मैम इट इज एब्सोल्युटली फाइन, यू जस्ट स्टार्ट विद योर
बोलना शुरू
प्रेजेंटेशन। आप
करूँ फिर
सेकंड
मैं?
स्लाइड चेंज। हाँ मैम,
Should I? Okay, thank you so
करिए
much.
मैम, करिए मैम।
पर ये फ्री मूव भी तो नहीं कर रहा है। ए भगवान, क्या लास्ट मोमेंट में प्रॉब्लम आ जाती है भाई।
मैम
मोनिका,
आप हम, हाँ मैम बताइए।
आप
मैम ये
मोनिका को मेल कर दो।
मैम ये प्रेजेंटेशन हमको मेल कर सकते हैं मैम?
हाँ, मोनिका को मेल कर दो आप।
मेल या व्हाट्सएप कर दीजिए।
हाँ, व्हाट्सएप ले लो मोनिका, आप अपने आप को मेल कर लेना।
मैं मेल कर दूं?
मेल कर दीजिए, व्हाट्सएप कर दीजिए, व्हाट्सएप पे भी
कुछ
आ
भी
जाएगा।
कर दीजिए, हाँ, किसी पे भी से भी हो जाएगा।
मेरा वो लो ना, पेन ड्राइव लो। 1 मिनट में दे रही हूँ आपको।
मत खोले लैपटॉप।
कैसे उनको शेयर कैसे करूं, लेकिन पेन ड्राइव कैसे मैं शेयर करूं पेन ड्राइव में आपके?
पेन ड्राइव में उसको खोलिए और उसको ड्रैग करके आप व्हाट्सएप वाले बटन में डाल दीजिए। व्हाट्सएप खुला है आपका लैपटॉप पे?
हाँ, व्हाट्सएप पे डालो, तुम करो पेन ड्राइव। हाँ
मैम अगर वो फुल स्क्रीन नहीं भी हो रहा है तो यू कैन स्टार्ट टॉकिंग, क्योंकि ऑलरेडी 5:42 हो गए। तो आप प्रेजेंटेशन आपका स्टार्ट कर दीजिए मैम। स्लाइड्स जैसे ही आप मुझे भेजिए,
शुरू में तो आ रहा था ना, नाउ इट इज नॉट कमिंग।
शुरू में
हमको दिख रहा है हमको दिख रहा है वो स्लाइड। आप प्रेजेंट करना शुरू कर सकते हैं मैम।
एक बार फिर दोबारा खोल के देखिए मैम।
इसको बंद करके फिर से पूरा खोलो जरा, सुनिए। किसी को खोलो ना, उसमें टाइम लगता है ना।
सुनील, एक सेकंड मेरी बात सुनिए आप। हेलो, हाँ, आप शेयर स्क्रीन पे क्लिक करते हैं ना, आप पावर पॉइंट पहले ओपन कर लीजिए।
अच्छा, पहले से पावर पॉइंट ओपन करते हैं?
ओपन कर लीजिए और
अच्छा,
वो फुल स्क्रीन मोड में कीजिए।
ओपन करो पावर पॉइंट,
फिर शेयर करिए।
हाँ, और ओपन करो और फुल स्क्रीन मोड पे करिए। आप स्लाइड शो मोड पे कीजिए।
इसमें करूँ ना पहले, उसमें बाद में लगा देना, इसको पहले करके देखो, नहीं तो जो हाफ है टाइम वेस्ट हो रहा है ना। इसको फिर से लगाओ, टाइम वेस्ट हो रहा है ना इसमें, लोगों का औरों का भी तो टाइम वेस्ट हो रहा है हमारे साथ।
आपको है ना मैम, जस्ट
डेस्कटॉप पे ओपन है ना?
हो गया।
हो गया मैम।
हो गया मैडम, कांग्रेचुलेशन।
थैंक यू सो मच। नाउ इट्स मूविंग आल्सो?
यस वेरी नाइस।
गॉड, दिस इज थैंक यू सो मच। आफ्टर अ लॉन्ग टाइम इट स्टार्टेड।
या डन।
ठीक है, तो मैं बोलना शुरू करती हूँ।
जी।
रुक जाओ, भागो मत। Good evening. I'm audible? I'm
Yes.
audible?
Yes, yes, very much.
Thank you so much. I'm really sorry for this problem.
Okay, no problem. No problem.
So today's topic basically on the preterm labor, in which I am going to speak on the etiopathogenesis of preterm labor. So according to definition, we know the preterm labor is when there is a uterine contraction resulting in the progressive cervical dilatation and termination of pregnancy prior to 37 weeks. The preterm labor may result in preterm birth. And according to WHO, it is classified as extremely preterm when the birth occurs before 28 weeks, very preterm between 28 to 32 weeks, and moderate preterm when the birth occurs between 32 to 34 weeks, and late preterm when the birth occurs after 34 to 37 weeks. Madam, I'm audible now? Huh? Kanchan, I'm audible? Oh,
Yes,
thank you so
madam,
much.
you are audible.
Yes, yes,
Audible.
thank you.
आपका वीडियो ऑफ है.
हाँ, मैंने कर रखा, मैंने कहा उसकी वजह से कहीं प्रॉब्लम तो नहीं आ रही है.
बहुत बढ़िया, बहुत बढ़िया.
हाँ. So come to the incidence. The global incidence is around 11%, equivalent to approximately 15 million babies born every year. The incidence ranges from 5% among the European countries to 20% in African countries. WHO estimates 15 million preterm preterm deliveries every year. The main burden of the preterm birth exists in the developing countries, including India. What is the major concern? Major concern of this preterm is because this is related to the antenatal hospitalization, neonatal morbidity and mortality, under 5 mortality, and long-term complication. These are the burden due to preterm labor. Now come to the diagnosis, how we can diagnose. The diagnosis of preterm labor is based on the clinical criteria of regular uterine contraction accompanied by the cervical dilatation and effacement, or maybe both. The initial presentation or the patient presents with the regular contraction and cervical dilatation of at least 2 centimeters. Sometimes the patient may have pain, but if there is no cervical dilatation, that is called the threatened preterm labor pain. If you go for the signs and symptoms, the symptoms are related with the uterine activity, contraction, lower abdominal pain, cramping, low back pain, sensation of pelvic pressure, passage of blood-stained vaginal discharge, and increased respiratory discharge. If you see the signs, there may be a palpable uterine contraction, engagement of the presenting part, cervical effacement and dilatation show, and rupture of membrane with sometimes there is a bulging of membrane. If you do the examination includes the routine examination and investigation. Sometimes the general examination can give clue about the cause. What about the predictor of the preterm labor? There are some predictor also, like in the symptoms, if the patient is having regular uterine contraction with the cervical changes. And sometimes we can measure also by ambulatory uterine monitoring. The external tococardiometer is tied around the abdomen with recorder, but it is expensive, time consuming, and not recommended. Measurement of fetal fibronectin is another criteria. When their level is less than 50 nanogram per ml, the patient is not going to preterm labor. So the negative predictivity is better. About the bacterial vaginosis test, again, there's as a theory that this infection can cause preterm labor. And if you assess the alkaline phosphate assay, more than 19 percentile is set to this patient can go into the preterm labor. So these are the few markers, even the salivary discharge level, but this is doubtful. But the length of the cervix is definitely the recommended for the as a predictor. If you measure the length, the cervix is less than 25 millimeter before 24 weeks of gestation, is called the short cervix. But if the length is less than 20 millimeter, this is the very short cervix. So measurement of the cervix is also important, but it should be taken into 3 diameter, and the shortest diameter should be taken for the cervical length. This is a picture showing the cervical length from measurement of internal os to external os. Now come to the preventive measure. There's so many preventive measures like antibiotic, activity restriction, omega-3 fatty acid, vitamin C, vitamin E, calcium, and protein. They are not recommended because they do not reduce the risk. And fish consumption may be protective, but the omega-3 fatty acid supplementation does not reduce the risk. But the role of cervical cerclage and progesterone therapy is definite here. Cervical cerclage can be given as a prophylactic cervical cerclage in the cases of cervical insufficiency when the patient is having history of unexplained second trimester delivery in the absence of labor or placenta, short cervix with the history of early preterm labor pains and it should be given between 13 to 14 weeks of gestation when after doing the NT&B scan. Sometimes rescue surclass is also work, but depending upon when the patient comes. So there is no benefit proven by the large and randomized trial. About the progesterone therapy is required for the maintenance of uterine quiescence. So if the patient is having history of prior spontaneous preterm birth, offer progesterone supplementation starting from 16 to 24 weeks of gestation. Whenever you are starting, you should start 16 to 24 weeks, because then the later on it may not be so beneficial. In asymptomatic women, or with the short cervix, it can be given in the form of vaginal progesterone therapy. In 17-hydroxyprogesterone acetate is also useful, and microprogesterone vaginal tablets are also available. So in this case, when the patient is high risk, we can use this progesterone. Now come to the causes and risk factors. If we see the causes, the actual etiology of the preterm labor is not known, although multiple factors triggers the onset of preterm labor as follows: intrauterine infection, inflammation, mechanical stress over distension of the uterus, intrauterine growth restriction, uteroplacental hypoxia and hemorrhage. The risk factors includes the maternal race, like it's more incidence is more in Black women and African American and Afro-Caribbean countries. It's related to the ethnicity, younger maternal age, advanced maternal age, cigarette smoking, low maternal weight, obesity, multiple pregnancy, use of assisted reproductive technique, and maternal history of preterm birth. So these are the causes, and high risk, the patient are more prone to go for the preterm. Then come to the etiopathogenesis. That is important. First, we have to understand why the patient goes into labor, preterm labor. If we see the causes, there may be genetic factors like cervical incompetence. In this, the single nucleotides genes polymorphs increases the inflammatory response to the infection and increase the production of matrix metalloproteinase, leading to preterm labor. Environmental factors like exposure to pollutant again is responsible for the reduces the immune response by inflammation. Autoimmune disorders like lupus erythematosus, lupus SLE, and systemic sclerosis, these all are the reduces the immune response and responsible for the inflammatory reaction. If you go for the infection like bacterial, viral, parasitic infection, again, they cause infiltration to the fetal membrane by maternal cytotoxic, CDBX cell, lymphocyte, monocyte, leading to increased genes expression of pro-inflammatory mediator and responsible for release of interleukin 1B, 6, and TNF. If you go for the psychosocial, like stress, anxiety, financial constraint, they are increases sympathetic activity and responsible for cortisol production with consequent production of corticotrophin releasing hormone, which leads to the preterm labor. Behavioral factors, smoking, alcohol, herbal medicine, they cause severe carboxyhemoglobin embryo. They are embryotoxic and teratogenic and leads to the preterm. And sometimes nutritional deficiency like iron, folate, low protein, they are responsible for the IUGR and preterm labor. So these are the factors which play very important role for the preterm labor. So if you divide the genetic, environmental, illicit, drugs, medication, and psychological, these are all responsible for decreased immune response to infection and ultimately leads to inflammation. Why? Behavioral factors like smoking, alcohol, nutritional deficiency, and medication in pregnancy causes increased sympathetic activity and causes IUGR restriction, growth restriction, and ultimately lead to preterm labor. If we go for the pro-inflammatory mechanism, in this, the intrauterine infection causes increased infiltration of fetal membrane by white blood cells, plasma cells, such as neutrophils, lymphocytes, and monocytes, and infiltration of the membrane of these cells can cause weakness, and activation of the receptor increases the gene's expression of pro-inflammatory mediators, including interleukin 1b, 6, 8, and TNF alpha, which suppressing the expression of interleukin 4, 5, and 10, which plays protective role in maintaining the uterine quiescence. So pro-inflammatory mediators causes increased production of prostaglandins, PGE2 and PG alpha, and these are responsible for the uterine contraction. So these are the factors how it acts by the pro-inflammatory mechanism. So this is the short how pro-inflammatory pathway causes inflammatory stimuli responsible for the circulating lymphocyte, monocyte, innate the immune system, and causes imbalance between the protective and creating pro-inflammatory reaction and release of prostaglandin. Ultimately, they're responsible for myometrial contractility and preterm labor. So in these, among the 4 main causes for preterm birth are like uterine distension, which are the commonly seen condition due to hydramnios, multiple fetal gestation. They cause activation of contraction associated protein, CAPS, reduces the expression of stretch-induced potassium channel concerned with the uterine relaxation, and early activation of maternal corticotrophin releasing hormone. So and like stress causes psychological and physiological action, and ultimately it causes increased CRH and ACTH, and ultimately leads to preterm labor. If you go for the infection, even the subclinical infections are also important for the onset of preterm labor and for the rupture of the membrane. So ultimately the inflammation would be the responsible for the preterm. PROM is due to rupture of membrane. There is a chances of preterm labor. So maternal stress, infection, abruption, uterine distension, they all are responsible for, they act on the chorion, amnion, and decidua, and responsible for release of protease and PROM, and release of prostaglandins acts as a uterotonics and causes a uterine contraction and ultimately leads to preterm labor. So there is imbalance of these effector T cell, exhausted T cell, functional T, regulatory T cells, which are more in the term pregnancy. In the preterm, there is an increase of activated effector T cells and impaired regulatory T cells. So there is an imbalance of inflammatory cells are more in the preterm labor and responsible for birth. So when you go for the summary, the pro-inflammatory mediators play a central role in the pathophysiology of preterm labor and may constitute the main target of therapeutic interventions in the prevention of clinical management of the preterm labor. So whenever we are planning for the management, we have to look after about the pro-inflammatory mediators role. Imbalance the pro and anti-inflammatory pathways may be responsible for preterm labor and post-term pregnancy, and increased expression of pro-inflammatory mediators such as interleukin 1b, interleukin 6, interleukin 8, and TNF alpha are associated with increased risk of preterm. Although the etiology of preterm labor remains elusive, the alteration in the multiple maternal fetal physiological mechanism are implicated, including the genetic predisposition, psychological, environmental influence. Is all play together. Sometimes they play together also. So the available medical therapies for the preterm labor have not been consistently effective in subsiding the uterine contraction during preterm labor due to, say, ill-defined pathophysiology. So the therapeutic intervention primarily targeting the pro-inflammatory pathway seems promising, and inflammation plays a central role of pathogenesis. In-depth understanding of the mechanism, role of pro-inflammatory mediators remains vital to the development of more efficacious therapies and intravenous prevention and treatment of the preterm. Thank you so much.
Very exhaustive presentation, Dr. SP. बहुत अच्छा था आपका. And I mean, what take-home message you have given? Best part is prediction. If you can predict with and gold standard is cervical length. If you can predict at the time of 18 weeks anomaly scan, then excellent like that. And then pro-inflammatory mechanism you should understand, and you should treat all factors beforehand.
Yeah.
Once it sets in preterm labor, then it is difficult. Whatever you do.
Stop sharing first so that we can see each other.
So excellent. Thank you so much. And I wish all the best to Dr. Mandakini Vaid for the upcoming winner. The great leader, great visionary, and she works for Foxy, a fellow Foxian, and Women Health Care of India.
There is no doubt.
Thank you, madam. This was
Mandakini Megam
presentation.
so considered about. She is very considerate about us.
She is one of the best leaders I have seen.
Very much. आप लोगों के इतने सुंदर शब्द सुन के बहुत मन
I wish you thumping victory. Not only victory, I wish you thumping victory.
Mandakini madam, I tried to explain the factors which are responsible for the preterm labor.
Very nice presentation, madam. It was a perfect presentation, starting with the ETU pathology and the prevention, and this include all the things. And
now next
perfect presentation.
Yeah.
Thank you so much. Thank you, madam.
Now please carry on the program because panelists are.
Thank you so much, Jaiswal ma'am.
1 minute. SP, thank you very much for coming to this program. In spite of there are many other parallel events going on. But
thank you, madam. This is my pleasure.
Usha Sharma madam and Chandravati madam also want, but physically she is held up. But I think you people are committed, and I think that commitment is seen all over, and all our delegates can feel that UP and we are one. That I can see that.
Definitely, madam. Thank you so much. Thank you, and wish you all the best.
Thank you.
Thank you, madam.
Monica, chala. Next chairperson.
Thank you, Jaiswal ma'am, and thank you, Rashmi ma'am and Kanchan ma'am for chairing this session. We move on to the next academic session, that is a talk by Dr. Mandakini Vaid ma'am. The chairpersons are Dr. Alka Sethi ma'am. She is a former superintendent, a consultant gynecologist at Cantonment Hospital, Jhansi. She was a president IMA at Jhansi at 21-22, a gold medal in obstetrics and gynecology with Vasu scholarship and total 6
self-explanatory. No need to waste time. The display is very visible.
Can I have the chair?
Thank you.
We welcome you, ma'am. The next chairperson for this session is Dr. Kanchan Prasad ma'am. Can we have her, Shri? She's a professor at Moradabad College, and she holds a fellowship in reproductive medicine and a diploma in ERT from Germany. She's also the North Zone coordinator for Foxy CRC committee. She has had the Champion of Foxy Awards in the year 21, for the C.S. John Tabor Prize at AISUG Bhubaneswar in the year 2018. She has been invited as a faculty at various conferences. We welcome both of you to chair this session, ma'am.
Thank you. Thank you very much. Thank you. Yes, at the outset, it's my proud privilege to be associated with Dr. Mandakini Vaid, who's very dear to me. And I had the opportunity of meeting her, and I brought her to my place. She's such an affectionate, down-to-earth person, and I'm really awed by her simplicity. She was so simple and so humble that I've not seen such a lady of high repute, and coming to a small society and coming to my house. And I'm really honored by your presence, and we wish you all the best for your future endeavors. Another feather in my cap was due to her only. I got ICUG because of her. And I'm very thankful to you. And you are the light. You are showing light to so many other young aspirants that keep continuing good work. And we need you at the helm of affairs. Now coming to the CV which is displayed, everyone knows Dr. Mandakini Vaid. She was the chairperson ICUG 2021. She is President Association of Medical Women in India Central Council, International Vice President, Central Asia, National Vice President, member of FIGO, member of AOFOC, past president of Indian Federation, and there is so much to her credit. She is just the lighthouse of Foxy, and I think we should start the topic without much delay.
Please allow me to share.
Thank you,
I'm not allowed to share, please. Allow me to share. Yeah. Hey, 1 minute.
Amit sir, can you please allow ma'am to share?
No, he has allowed me, but my presentation I must see. 1 minute, 1 minute. मेरा presentation इस चक्कर में कहीं हो गया है. Please bear with me. एक मिनट. मैंने खोल के रखा था और फिर पता नहीं कहाँ चला गया. So presentation. एक second. Sorry for the delay. You can speak in between whatever you want. I'm just trying to locate my presentation. कुठे चाललं गेलं? एक मिनिट. मनिका, थोडी गडबड झाली कुठेतरी. कहाँ चला गया? बाप रे, आज क्या हो रहा है? हाँ, अभी हो गया. Yes, I got it. Got it. Yeah. Now I can share together. Is it seen now?
Your CV slide is visible. You'll have to do slide.
One minute.
Yes, we can see the first slide.
Okay. Share. Is it okay now?
It's not in full screen.
I'm coming.
Now it is okay.
Yeah. So 1 minute, because now nobody's seen here, because it's okay. Am I audible now? Okay.
Yes, very much.
Yes, ma'am, you are audible.
Yeah. So first of all, I'd like to thank my chairperson, first the chief guest. In spite of their busy schedule, they made it a point to come, showing their solidarity to this program and to us also. Second thing, all my lovely chairperson, Dr. Alka Sethi, you are really so nice, and I can call your home as a, I can call it a palace of Sethi Palace, where I have been, and it was wonderful, I'm telling you, to be with you in Jhansi. And my other chairperson, young, bubbly, Dr. Kanchan Prasad, we are on the many social platforms, and we really like each other so much. So thank you for this. And my previous speaker has done a great job of, this preterm labor. And actually there are some slides which are going to overlap, because I have also explained the preterm labor etiology in some of my slides. So please bear with me. I start always with this very famous quotation of our Muhammad Patala, President FIGO 1997, saying that the women are not dying because of the disease we cannot treat. They are dying because societies have yet to make the decision their life or worship. And this actually statement is so much true today also, because the women's health is still should take the top priority in the agenda of the country. So preterm labor, the problem and its significance. Globally, every year, 15 million babies are born prematurely, and 1 million babies die due to complications of premature birth. In India, out of 27 million births, 3.5 million are premature birth. Overall rate of premature labor is around 22%, and preterm birth is at 20.9%. So what is a great significance? And also, what are our SDG goals? We are very fortunate that we could achieve the goals of maternal mortality and all over world, we are being applauded for already achieving 2030 target in 7 to 8 states, with Maharashtra, Kerala being on the top. But same should be with the, neonatal mortality. Same should be with your, other mortalities for the children also. So in order to have that SDG goal, this is a great significance for the maternal child health. So preterm labor is a major public health problem. It accounts for 43.7 of all neonatal death, and prevalence I already talked about. Definition, I will not go into the detail. Already my previous speaker has beautifully explained. But subdivision of the pre-birth is very important. Preterm birth is a late preterm, maybe 34 to 36 weeks. Early preterm, maybe 32 to 34 weeks. Very preterm, maybe 28 to 32 weeks, and extremely preterm, 28 weeks. So this is a second leading cause, which we have explained. An Indian scenario, we can see nowadays so many NICUs and so many children ward and everything is created, but every ward is full. So why there is so much of need for the NICUs and other neonatal cares? So 60% of the preterm birth occur in Africa and South Asia, which is very important. India tops the list, and the survival depends upon the socio-economic status, varies from 9 on 10 in the some states, 1 in others. So increase incidence, because there are NCD increases. Kanchan will agree with me, diabetes and so many things, and causes are already told to us by previous speaker. So because of the increased incidences of other adult diseases, there is an increase in, with the prematurity also. Then if we look at the why? Because the rising rate of preterm labor, because of the young advanced, either they are too young or advanced maternal age, low BMI, short interpregnancy intervals. I can see, I think those who are in the government sector or in a big hospital, there by the year 19 or 20, she completes her family. 3 children already over. Pre-existing non-communicable diseases, I have already mentioned. Infections, increasing physical and psychological stress. Iatrogenic preterm between 35 to 37 weeks. So the iatrogenic may be the causes very, very important. That is preeclampsia, fetal distress, small for gestational age, abruptio placenta, placenta previas, diabetes, renal diseases, Rh isoimmunizations, congenital malformations, and unexplained bleeding, chronic hypertension are few of the causes. So the late and moderate preterm may be associated with the cerebral palsy, poor school performance, early intervention services, special education needs, and asthma. I like to mention here, yesterday there was medical legal panel wherein actually there was a case being told by Dr. MC Patel, where they have not predicted the premature preterm labor, and the baby was asphyxia, and later on developed the neurological complication, and hospital was told to pay 1.4 crore, including the gynecologist was given the penalty of 48 lakhs. So it is so important from the point of view of the obstetrician and the practicing, that you predict, you actually anticipate, then predict and treat the preterm labor. Now, the current understanding pathology underlying preterm labor, I won't go into the detail because Dr. Jaiswar has beautifully said, but just to touch upon that, the most important causes may be drug abuse, then there may be multiple pregnancies, then the teenage pregnancies, previous cervical surgeries, and previous late miscarriages, asymptomatic urinary infections, previous preterm deliveries, advanced maternal age, bacterial vaginosis, and smoking may be few of the causes for the preterm birth, which I explained. Now, how do we predict the preterm? So there are various scoring systems based on the risk factor and obstetric history. Only about 30% of the preterm births are predicted correctly, and low specificity make it difficult to base the intervention on this. So actually, I think the other day I was giving a lecture on the artificial intelligence. So the most important application which was discussed was AI in the predicting the delivery, predicting the labor, and which is going to solve lots of problems. And it has also said that there is unnecessary expenditure. Suppose you say that it is baby will be premature, then there is an ICU, then there is so much of medicine, and then later on so much expenditure. So this unnecessary expenditure can be prevented if the AI application in later stages can be applied for the preterm labor. Then currently useful predictor are previous history of preterm labor and other risk factor. Of course, we are going to ask the history. Transvaginal ultrasound will give a, lead to the diagnosis, biochemical, then fetal fibronectin and the salivary history are important. Screening can be started at 16 weeks in suspected cervical insufficiency as per the ACOG guidelines of obstetric gynec. Now the cervical ultrasound. Assessed by the TVS probe should be kept the anterior fornix. Aspect to look at length, 25 millimeter at less than 24 weeks. Internal os opening and its diameter, shape T, Y, V, etc. I think so. This is one of the important investigation which Dr. Dayaswar has also mentioned. You can see here the cervical length and the uterus, everything should be marked. And fetal fibronectin, the extracellular glycoprotein located on the decidua and the fetal membranes. After 22 weeks, its presence in cervico-vaginal secretions is abnormal presence due to separation of decidua and membranes and inflammatory markers. Now the FFN has a role for predicting the preterm birth in low risk asymptomatic women. So just now, and the value of FFN probably lies in its negative predictive value, that is this 95%. And negative FFN virtually rules out the preterm labor risk and can reduce the admission, and which I have mentioned that unnecessary predicting the preterm labor and causing so much stress to the patient and the economic this thing also financial stress. What are the other biochemical markers? It may be salivary histriol, it may be blood cervicovaginal secretions, it may be corticotropin releasing hormone, and the interleukin 6 and blood assay may be beta HCG, alpha fetoprotein, glycoprotein such as activin, inhibin, and relaxin. So these are the other markers, and these are the combined markers. You can see here that if the cervical length is less than 25 millimeter, then the 3.7% chances of delivery at 35 weeks, 9.2 and 18.4, and all both the tests are positive, then the 35.3 at the 32 weeks, 50.8 and 64 point as per the Goldenberg et al. AJOG at the 2008 guidelines. Now the current test for the prediction of preterm labor of value history of preterm cervical length and fetal fibronectin is most important as far as the tests are concerned for the prediction of preterm labor. Tests have high negative predictive value and can be used to reduce the unnecessary intervention. A policy of screening low risk population and subsequent intervention should be subjected to a large scale trial. But it is very difficult for us in India, a low resource country where the screening for such kind of can be done. Even the screening for the diabetes is also just at the, is at minimal level, which we want to increase as the NCD screening methods. What are the aims of intervention? Very important to prevent the preterm birth. Obviously, and to prolong the interval between the threatened preterm labor and delivery at the tertiary healthcare unit, to optimize the condition of the fetus in preparation for the delivery in order to improve neonatal outcome and corticosteroids, minimize the maternal morbidity and also adverse effect for the treatment. And also the last but not least, the medico-legal complication, which I have already mentioned. There are 2-3 cases which are going on against the obstetrician. Now the prevention of preterm labor for the general population may be lifestyle modifications, smoking cessation, modifying the physical activity, and for selected group, if there is a cervical incompetence, then cervical cerclage, antibiotic, progesterones are the for the selected group. Now, this fetal fibrinogen positive women with the prior history of preterm, this is a risk which have been given here 65%, and here again you can see the negative with the prior history. Then it is less, that is 25%. So you can study, you can predict, and according to the report you can have your interpretation. So intervention and prevention, primary aim for all women. Secondary aimed at eliminating or reducing the risk in the women with the previous preterm birth. Secondary, and that aimed at the preterm infants. So primary prevention, I think we in Maharashtra, we have many preconception counseling clinics are there in few areas where if there is history of preterm labor or other bad obstetric history, then they give the planning, maybe contraception, family planning, all those things are given as per their report, genetic reports and other things. Smoking cessation, tobacco chewing, improved nutritional status and avoidance of late preterm births is given as per this study. Secondary prevention may be targeted to women with the risk factor preterm birth is that is a past obstetric history, previous preterm birth or no uterine anomaly, and presence of the pregnancy risk, that in multiple gestation, gut infection, BMI, very low or very high. So these are the secondary prevention. And measures now will be, definite measures will be progesterone therapy, cervical cerclage, referring to the dedicated clinics, that is a fetal medicine. I think we all over India now, we have fetal medicine specialist and our gynecologist also we have, and neonatologist and antibiotics. These are the secondary preventions. Tertiary prevention, very important. The is to preventing delivery or improving outcome for the preterm infant by referring to the regional perineal care center. So you, from the beginning, you are referring this patient to the tertiary prevention center. The measures for the prevention will be tocolytic agents, then antenatal steroids, magnesium sulfate before 32 weeks. For neuroprophylaxis and antibiotics will be tertiary prevention. So all efforts must be made to prevent, and not just early, that is less than 34 weeks, but also the late preterm to avoid the iatrogenic prematurity unless strong obstetric indications are there. So what is the significance of Mexal for the neuroprotection and the progesterone for prevention of preterm births? Very important from the point of view of prevention as well as the therapy. So Mexal for the neuroprotection, currently recommended in less than 30 to 32 weeks, started with the women with eminent preterm birth. Then the modest effect greater with earlier gestational age at delivery to prevent one case of CP varies from the 46 pregnancy less than 30 weeks to 34 weeks. So this MGSO4 is for mainly for neuroprotection. Then doses recommended as per the RCOG, ACOG, 4 gram IV bolus for every 30 minutes, followed by 1 gram per hour for a maximum of 24 hours till the delivery occurs. Also insufficient evidence for a repeat dose. So here I would like to mention that even in India, where many of the patients come from the rural area, where the ANM and other nursing staff are empowered to give the Mexal, provided it is being ordered by the senior, and they can actually inject or take care of their IV injection server. So previously even the injections were not given by the nurses, but now because they are the first point of contact, because they are there in the periphery, and then they can ship the patient to the secondary or tertiary center. Then these are the this neuroprotection proposed blocking calcium process, acting as a vasodilator, and also delays the cell death after the cerebral ischemic events. That is one, and decreases the production of pro-inflammatory cytokines. Dr. Jaiswal has said ki, the main cause is the inflammatory. So it is decreases the production of pro-inflammatory, and also increases the level of brain-derived neurotrophic factor that is shown to be protective against the neonatal hypoxic ischemic. So these are what are the contraindications? Myasthenia gravis, maternal side effects, flushing, lethargy, headache, diplopia, dry mouth, etc., lethargy, hypotonia, respiratory depression. These are the effects, and reduces the severity and risk of the CP in the surviving infant. So these are important indications, and also the beneficial effects of the MGSO4. And also it has raised some fetal concern. What were the concerns that is which are subsequently discarded in the meta-analysis? That is, caution would include the periodic monitoring and ready availability of calcium gluconate in cases of toxicity. So one has to observe if there are any signs of toxicity. This is a busy slide. I will share, but these are the doses and follow-up of the current tocolysis at a large trial. Then minor maternal complications were more common, but serious maternal complications were not very frequent in these studies. Then now come to the progesterone role in the safe motherhood includes the luteal phase defect, recurrent pregnancy loss, preterm labor, which we are concerned with. So normal cervix here, and then short-term cervical, short cervical length you can see, and also the withdrawal of the uterine quietness and the initiation of the uterotonics and maintenance of the uterine quiescence. So myometrial, because what it does is a relaxation of the myometric, because progesterone inhibits the this connexin, and it actually quiets the atmosphere inside the uterus, blocking the action of oxytocin, inhibition of the formation of the gap junction, and also the protection of and also the alteration of the PR ratio. So what is the mechanism of action of progesterone? I did not tell in detail. All the learned people are all the time using here the progesterone. It maintains the uterine quiescence. It is at the fetal membrane. It works to block the inflammatory cytokinase at myometrium, cervical level, amniotic, and placenta. It's very beneficial for preventing the preterm labor. So progesterone, oral micronized progesterone can be given 300 milligrams as tablets, or maybe micronized progesterone capsule 200 to 300 milligram, vaginal micronized progesterone capsule dose 100 to 200, and also intramuscular progesterone injection 100. So these are the progesterones may be given, and role in maintaining the uterine quiescence, and the anti-progesterone are abortifacient. We must say mifepristone is a abortifacient. So the opposite is true. That is it makes the uterine atmosphere quiet, and excessive activities are not there of the inflammation. Some mechanism of progesterone withdrawal, selective disruption of the functions at a play at the human parturition. So these are the guidelines of the progesterone given from the robust evidence from the latest guideline. You can see all these are the guidelines. I will just see the FIGO guidelines, NICE guidelines. FIGO guidelines for the short cervix is given. I think this chart is very useful. And progesterone is an alternative to cervical cerclage. This study says vaginal progesterone versus cervical cerclage. And in conclusion, they said that this is based on the state of art methodology. Vaginal progesterone and cervical cerclage are equally efficacious in prevention of the preterm birth in women with the sonographic short cervix in mid-trimester singleton pregnancy. So progesterone is an alternative to cervical cerclage. In Indian experience, it is again a study. And in conclusion, that they found that natural micronized progesterone is effective as a cervical cerclage in prevention of the premature labor. So these are the various studies. I will not go in the details, but finally they are giving the, they are reassuring and again saying that they reaffirm the progesterone in the preterm birth. Safety issues with the progesterone, then the side effects are site reaction, etc., very minor. No teratogenic effect, no rise in the mid-trimestral loss, no risk of the gestational diabetes, etc. So I think it is very, very beneficial and can safely be used. So friends, the take-home message for this will be that risk of the preterm labor, short cervix, multiple gestation, history of PTB, guidelines across the globe support the progesterone treatment for the prevention of preterm labor and associated morbidity and mortality. And also we have to, use the this MGSO4 also in some cases. So motherhood is very challenging. Let's give her full-term baby for enjoying the bliss of the motherhood. And also, last but not the least, I am contesting for the post of President Foxy. I know that you will be voting for me, but please support me and propagate my name everywhere. Thank you very much. Thank you. I have exceeded little time. Yeah.
Thank you, Dr. Mandakini, for such a beautiful, enlightening talks, starting from the etiology, pathogenesis, management, preventive aspect, everything. And you've really covered all the topics in such details with latest, as you are very much research minded. I know you are full into research only. You've shown all the papers which have been published latest, and premature delivery should be avoided because it's a pediatrician's nightmare. So it is our moral responsibility to curb all cases of prematurity, diagnose them, prevent, so that a healthy mother and a healthy child is born to the nation without any mental retardation or without any defects. Dr. Kanchan, would you like to conclude or say something about?
Yes, ma'am. Thank you. Thank you so much, Mandakini ma'am, for giving me the opportunity. And we all know ma'am is a academician par excellence, and we all are inspired by her energy level. So how active she is. Ma'am, I have only one two queries. What tocolytic you prefer, ma'am, when patient is on magnesium sulfate for neuroprotection?
Ek minute. Actually, I have kept that ready. Can I take a minute here? Can I take a minute? Yeah, because in a tocolytic, there was 1 minute.
मैम आप मतलब आप क्या देते हैं मैम जब पेशेंट को इफ यू पुट ऑन मैग्नीशियम सल्फेट?
एक सेकंड. ये देखो, ये टोकोलिटिक का पूरा we have studied that we are all the time giving the this MGSO4 and also the using of sometimes we use the corticosteroids also as per the studies, and also we can do the these are the meta-analysis which gives the importance to the short period during the corticosteroids, and also we give the MGSO4 which I have already told. And what do you give in your practice? Tell me that.
Ma'am, I give the duodenum, ma'am, because
yeah. Hey, progesterone, you give duodenum.
Progesterone is then when active contraction is not there, then we give progesterone. But when active contraction is there, plus we give magnesium sulfate for neuroprotection. Plus
magnesium and the duodenum you say. So I endorse your views. That is correct. Yeah. Then or Kanchan pucho.
Or ma'am, what is you were talking about role of artificial intelligence in predicting pre-birth?
I will tell you in detail because my oration was there on the artificial intelligence. I was very impressed because I did a lot of research, and there was two indications. That was one indication was very important, was a prevention of preterm birth. And then I went in detail. I read books. They say because the obstetrician predict around 65% time, they predict a wrong timings. And I wanted to have actually evidence why they are saying so. So I found evidences. You can have a study. I have a paper also. I'll share with you. Then they say Indian or anybody, if you predict wrong, then you are unnecessarily harassing the patient and also the doctors. Economically, it is so much burdensome that you prepare for NICU, this, that, etc. And then it becomes a really, really chaos. So if you use the artificial intelligence, which includes the AI monitor, fetal monitors, they have shown, and other also AI in the labor, so it will predict accurately, so 95% is accurately, so that you are saved of all these things. And I'm really impressed. I share with you my presentation.
Yes.
And it was very well taken. And I also learned while preparing the presentation. So thank you very much.
Thank you. Thank you so much. It was excellent talk, ma'am. You explained everything so well. Thank you so much, ma'am. Over to Dr. Monica.
Thank you, ma'am. Thank you, Alka ma'am, and thank you, Kanchan ma'am, for chairing this session. And Meg ma'am, it was an extraordinary coverage of the topic. We now move forward for the next academic session, which is the panel discussion. Can I have the slides, please, sir?
One minute, I want to thank my chairpersons. 1 minute, Monica. Dr.
Yes, ma'am.
You were wonderful, and I think your visiting your home was really. I think I did a very good thing by visiting Jhansi, and their palace and everything. And Jhansi people are so good academically. They kept very good lectures and academic program. So thank you for being there and always with me. And Kanchan, thank you. I really want to thank you. Like a younger sister, you are always there. And when I met her, she just came to one of the AICOG. She said, "Madam," I said, "Yes, I'm your Facebook friend." That was long back. And still now she's such a
You remember, ma'am?
professor, and I think loving person, and all the time with me in my all ICUG programs. Rashmi, thank you very much for talking so nice of me, and also being always with me. And also with the Rashmi, I'll take a small time. Rashmi, last time ICUG chairperson I was contesting, I phoned her. Arey, she spoke in such a good Hindi. I said, "Aap kya Indore ke hai kya?" She said, "Oh, madam, मैं भोपाल का." I said, "मैं भी इंदौर की." And then we clicked on like a very good friends, like a sister. And Sanchita, we were on the very big Goa beach on some very scientific program. We picked up the oratory skill. We were improving our oratory skill, and she was impressed with my oratory skill, and she called me to give an oration in the Noida, 2015, 2016.
Yes, ma'am. Yes, ma'am.
So thank you everyone, and also Anju, you were there in Noida, my COG fellow. So everyone touched my life, and I touched in their life. Thank you very much, everyone.
Oration, apart from oration, your presentations are excellent. Everybody will be agreed with me. आपके presentations
Impressed with her presentation. Yeah.
presentations you have.
Thank you. मैं खुद तैयार करती हूँ. By the way.
अरे वाह मैडम.
मैं खुद करती हूँ. I was telling my secretary, देखो मुझे लोग पूछेंगे ये किसने तैयार किया तो बोले nobody will know कि मंदाकिनी मैडम खुद के presentation तैयार करती हैं.
अरे वाह.
कहाँ कर दिया तुमने?
उठेगी Monica, please continue with our all the panelists. Yeah. All the panelists.
May I have the slide, please? Amit sir, can we share the slide, please? Our moderators are Dr. Anshu Raina, madam. She is presently heading the Obstetrics and Gynecology Department at Apollo Cradle, Greater Noida. She is also a laparoscopic surgeon. She is the head at the Apollo Cradle Center, Greater Noida, and secretary of the Noida OBGYN Society for the year 1921. She has been the joint secretary for Foxy North Zone Yoga Conference and the former consultant at Max Hospital, Noida. Our next moderator for today's session is Dr. Sanchita Dubey, ma'am. She is a senior consultant at Apollo Hospital, Noida, director Evidence Healthcare, Noida, vice president at Noida Obstetrics and Gynecological Society. She has been the joint secretary, the honorary secretary, and an executive member since past so many years, and the member of the HIV and AIDS committee for the year 17 to 21. We welcome both our moderators to continue the panel discussion. But before that, I would like to introduce our panelists. Our panelists include Dr. Seema Hakim, madam. She is currently the coordinator for Medical Education Unit, the Faculty of Medicine, Aligarh. She is a nodal officer at the Regional Resource Center and Project at Aligarh, the presiding officer of the Internal Complaints Committee, the vice president of UPSCOG, and the president of AOGS. We welcome you, ma'am. Our next panelist is Dr. Savita Tyagi, ma'am. She is a director at Ishwar Nursing Home, Agra, a chairperson of the Rural Committee INL 2123, the chairperson of the Scientific Committee AOGS, the past president of Agra Menopause Society, and the secretary of the Agra chapter of Menopause Society from the year 17 to 19. She has received many awards. We welcome you, ma'am. Our next panelist is Dr. Anju Jain, ma'am. She is a gold medalist in her post-graduation, holds a postgraduate diploma in medical law and ethics, and has done an ICMR course on genetics and genetic counseling. She holds a diploma in hospital management and has been certified in the course of fetal ultrasound from FGR. She is the director of Jain Hospital, Varanasi. We welcome you, ma'am. Dr. Rachna Pandey, madam, is a senior consultant practicing at Vasundhara Hospital, Ghaziabad, formerly at Gauri Hospitals and Bridge IVF. She is also part of the Indian Red Cross Society Hospital, and special area of interest include the high-risk pregnancies. Dr. Preeti Vaish, madam, she is the president of the Bareilly OBGYN Society, the vice president of Bareilly OBGYN Society, and ex-registrar medical college at Kanpur. She has completed her MS in 1990 with the previous medical college, now practicing in Bareilly for the last 27 years, and the owner of Swasti Hospital, Bareilly. Our next panelist, please. Dr. Parul Garg, madam, will not be able to join, ma'am, because her mother is not feeling well. So we can continue with the panel, ma'am.
Good evening, everyone. I'll share my screen now. Can you see my screen?
Yes.
All right. First of all, thank you very much, Dr. Mandakini, Dr. Monica, for giving us such an opportunity on a national forum. And Dr. Mandakini, I have a very close and a very friendly relation, though she is so senior to me, but she has always been a very good in friendly terms. And I really admire you, ma'am, and wishing you all the best for your success. Without this thing, the panelist has already been introduced. So me and Anshu will go through the panel discussion. We have tried to keep it short, and we will try to cover as much as dilemmas we can. Welcome Dr. Seema, Dr. Savita, Dr. Anju, Dr. Parul, Dr. Rachna, and Dr. Preeti for being our panelist. And we are privileged to have such knowledgeable and seniors with us for this panel discussion. See, preterm,
we are also equally feeling honored to sharing stage with such eminent people.
Yeah, can you make it full screen? Yeah.
Yeah, I have done it. It's done. Okay, so we all at some point of our career, we have got stuck with preterm dilemmas. And here we will be navigating the complexities of preterm labor. So be it, the decision depends on exact gestation age. Sometimes there is a disparity. So we have to be very clear on the gestational age. Tocolytics itself is a complete topic for discussion, which tocolytics to be given, which is most appropriate, most effective with least potential side effects. Timing of delivery, again, is a very, very tricky situation. We have to balance the risk associated with prematurity and as well as the potential risk of continuing the pregnancy. So that is how the dilemma is an appropriate word for managing preterm labor. Then when to give steroids, how to be concerned about the neonatal intensive care resources, informed decision-making. I mean, you have to involve your patient and the relatives on this. There are so many questions, so many queries, and you have to be constantly updating them and making them aware about the prognosis of mother and baby as well. And of course, it is a multidisciplinary team approach, obstetrician, neonatologist, and fetal medicine specialist who need to be proceeding further in managing a preterm labor. So we come down to our first case. This is Mrs. ABC. She is 32-year-old, primi gravida. She presented to labor and delivery ward. She is 28 weeks gestation with signs of preterm labor. She has no significant medical history. She reports experiencing regular contractions, mild to in the lower abdomen, abdominal discomfort for a few hours. So, Dr. Seema, my question for you would be, what would be your initial management step for her? Dr. Seema? Dr. Seema has not joined. No, no reply. Any of the other panelists can take over the question. Dr. Savita, you can start.
Yeah, this patient is in, has gone into the labor, preterm labor. And as we all know, the complications associated with the preterm delivery, we have already discussed. CNS complications, respiratory complications, GIT complications, all are there. Our main aim is to extend this pregnancy at least up to the 48 hours to give the corticosteroid therapy as well as neuroprotection by giving the magnesium sulfate administration. So we have to start all these two things, corticosteroid like beta-methasone.
Ma'am, we will come back to that. The initial management, I mean, how would you proceed in taking the history, any specific point which...
Yeah. Whether this patient has any history of a previous history of any abortion or any drug intake.
She is primary gravida. This is her first pregnancy.
Okay.
Okay. So when the patient has arrived. Yes, ma'am.
Can I answer? Can I
yes,
answer?
Yes, Dr. Anju.
Actually, it is you have just presented the complaints of the patient. We need to ask we have to examine the patient and we need to ask few direct questions. We have to first establish whether she is in true preterm labor or it is something else which is she is bothered of. We have to first find out. So,
so after examination, I mean, you have done a per abdominal examination, you have measured the contractions. So she was having regular contractions, and on per vaginal examination, the cervix was 3 centimeters dilated, 80% effaced. You have done the fetal monitoring, fetal heart rate pattern was assuring, and there is you would like to go ahead with the ultrasound as well to understand the exact gestation, the weight and things. So you need to know the location of the placenta from a previous scans, and any other medical complication associated, either it's a preeclampsia or she has a history of bleeding and all. So everything has been ruled out.
Without any kind of infection she might be having, like UTI or something.
Yes, like so for infection, what all tests you would like to go ahead? She has come with the pulse is fine, BP is fine. Now, what all you would like to go ahead?
Blood count, CBC is to be done to rule out any infection. Urine should be done to rule out the high vaginal swab we can take. Then we have to like admit the patient after that. First and foremost will be at least secure a vein, and then we can take the samples, and then we can proceed for the management part.
Okay,
so we will for the PS examination if any discharge is there.
Yes. So there was a little mucoid discharge. She is already dilated 3 centimeters. This is her first pregnancy, and she all of a sudden has started. No other significant past history she had. So we will definitely go ahead with CBC. In our center, we do go ahead with the CRP also, so that we can then have a follow-up, because our pediatricians are very concerned about that. And of course, we take a high vaginal swab and we go ahead with it. Now, the next question is, what is the role of tocolytics? What drug we should choose, what is the dosage, duration, and what are the contraindications of the drugs? So who would like to take this question? Dr. Rachana?
Actually,
Dr. Rachana?
Yes,
Dr.
tocolytics, as far as tocolytics is concerned, I think basically she is in active labor, 3 centimeter, 80% effaced, shows she has already gone into preterm labor. So what is our main aim is to prolong it and give corticosteroids so that at least the lung maturation part of the fetus can be taken care of. That's what I think, because to prolong this pregnancy to a much longer period, I think it will be very difficult. So to at least gain that much for the fetus will be, I think, a better option.
Perfect.
So I think I'll go with antibiotic. definitely I'll go with an antibiotic, start the patient on an antibiotic.
Prophylactic antibiotic, yes.
Yeah, prophylactic
So
antibiotic.
perfectly, I mean, here the role of tocolytics is only two. One, to extend the pregnancy for at least 48 hours so that we can achieve the effect of antenatal corticosteroids, because it's extreme preterm, it's just about 28 weeks. The second purpose of tocolytics is if the center is not having a appropriate nursery care, then it is good to transfer a woman in utero to a proper center. So the purpose of tocolytics is only two. One is the lung maturity, and second is to transfer in utero. So whichever the center is nearby, you can go ahead with it. Okay, so the choice of
the drug is atosiban, because it is an antioxytocic and it is proven anti-tocolytic drug and have better tolerability to the patient and to the fetus. And to start with, you have to give 0.9 ml one vial in 1 minute as a loading dose. Then 1.5 vial is mixed with a 500 ml of saline, and it is given at 60 drops per minute. That is 300 microgram per hour. And total doses, it is given for the 9 hours. Then 3 hours as a 120 drops per minute. Then the next 6 hours, 20 drops per minute.
Perfectly all right, ma'am, but atosiban is pretty expensive, and this one therapy may cost as good as 20 to 40,000 to the patient. So we have to understand the affordability of the patient as well. Even in the private sector, it is very difficult to convince any patient with such expensive drug. So the dosage, yes, this will go on for 48 hours. You give a loading dose of 6.5 mg bolus, then 18 mg per hour for 3 hours, and then 6 mg per hour for 45 hours. So complete 48 hours you can give. But how, I mean, of this so many years of practice, I have given only one case atosiban. So we have to think of other options as well. What other options, Dr. Rachna, would you like to give?
I think
whatever you're practicing in your practice.
Nifedipine, I am more comfortable with that to prolong the nifedipine.
Okay, so the dose of nifedipine is 20 mg and then 10 to 20 mg every 6 hours. Okay, yes. And this is for 48 hours, right?
48 hours, yes.
Any other medicine would you like to start? Any one of you, Dr. Anju?
Actually,
Dr. Anshu, you can also take a part because we have only 3 panelists, so we can be one of them.
Actually, 28 weeks is very borderline case. Even with best of nursery care, the chances are grim. So I would like to transfer this patient in utero, explaining everything, and that too in utero also, like during transfer also she can deliver. So this has to be explained to the attendant. And like magnesium sulfate as a neuroprotective, though it has a role, but still we cannot guarantee cerebral palsy will not develop. So these things, because I am doing high risk pregnancies, these things have to be told to the attendants and patient beforehand. Even though we are starting nifedipine, I have seen these, they don't help. She might deliver within 3 to 4 hours. So this so all tocolytics, terbutaline, even terbutaline, or if nothing is available, we do try duodenalone also, though it is not going to help. That is what I'm talking about, the practical aspect. And nifedipine, it is not a sure drug that it will stop preterm labor.
Here, I would like
that is true, ma'am. But at times we have seen 2-3 centimeters. Once the contractions
are
under control, if they stop, then they can pull through a few weeks as well.
Definitely.
Even if the chances are glimpse, even if there is 10% chances, we have to try full.
We do take, but I am using nifedipine only. I am using nifedipine only.
I am also comfortable with nifedipine.
Shifting, even if you are not at a center where you have a good nursery care and you want to shift the patient, always coordinate with the center from where you are shifting, call in the ambulance, shift the patient under care. Otherwise, suppose if you have just referred the patient and patient delivers somewhere in between, then apart from the preterm discussion, we will land up into a medical legal discussion.
Definitely.
So you have to have a tie-up, or you have to arrange. I mean, you have to get the ambulance either from your hospital or from the center from where you are shifting the patient, so that she is shifted under supervision. That is one point.
Interrupt, because we are discussing tocolytics, and although we all are knowing that no literatures are supporting very much isoxaprine, but still, very frankly speaking, all of us are using isoxaprine, and it's very much effective.
True.
Even if the Central Drug Standard Control Organization in India, it's proven the multiple studies proven that it's efficacious, and we can use as a cheaper agent, and it's effective. So there is no second thought, and even in India we can use as isoxaprine.
And for this patient, I think magnesium sulfate is a good choice, because it is going to give a tocolytic as well as a neuroprotection. So the dose of magnesium sulfate which we give is, yes, ma'am.
But with a word of caution, if you are using a calcium channel blocker and magnesium sulfate simultaneously, then it can be dangerous. Yes,
you don't have to use both.
see.
You can choose only magnesium sulfate, which will provide you both.
Yes.
It will give a tocolytic effect as well as it will give a neuroprotection. So the dose of magnesium sulfate is 2 mg bolus, a slow IV, and then 1 mg per hour. You can just continue for 24 hours.
Yeah.
24 hours. Yes. Okay.
Many times it is very effective.
Yes, it is. It does. I mean, it gives you a both. So if it is 28 weeks, less than 32 weeks, you should think of magnesium sulfate, which one drug will solve both the problems. So we have discussed the drug, we have discussed the dosage, the duration. So tocolytics to be continued for how long?
Till the patient is transferred and a corticosteroid cover is given. That's it. That's
48 hours. That's it. 48 hours. After that, you stop. If she prolongs her pregnancy, it's very good. If she's not able to prolong it, we can't do anything. It is just that we have given this thing cover and we have shifted. So duration of therapy is 48 hours. Now, what do you think about maintenance tocolytic therapy? Anyone in favor of it?
If the pains have stopped, if it's a quiescent
if it has
uterus,
worked,
yes, we can. But like studies have shown, if patient is already in an established preterm labor, maximum we can gain 7 to 8 days. So it
but
has
at
to be
least I
discussed with
think
the patient.
7 to 8 days is also good,
Very
as long
good, very
as you
good.
can give the fetus. It is, I think that chance should be taken.
Yes.
So 48 hours for all. If it doesn't settle, then you can continue the maintenance tocolytic therapy with the nifedipine for 7 days.
Yes.
That can be continued in extreme preterm cases like this. All right. So magnesium sulfate we have discussed. It is a neuroprotection, impending preterm birth and multiple gestation also you should give magnesium sulfate. Now, contraindications. Whenever you start tocolytics, you have to be very careful about certain medical condition of the patient. You should know that there is no medical complication, like if there is a preeclampsia or eclampsia, then it is not good to hold on to the pregnancy for the mother's point of view. Baby is preterm, agreed, but our first preference should go to the mother. So if the mother's condition is not fit to continue with the pregnancy, you should not delay it for 48 hours also. And of course, in cases of maternal bleeding, in cases of abruption.
Is there. Amnionitis is there.
Amnionitis, yes. True. So antenatal steroids and role of antibiotic, we have already discussed. Now, this also we have discussed what measures can be taken to optimize neonatal outcome. Yes, first we need to shift the patient to a better center where things can be taken care of. So what are the main fetal complications in a preterm birth? Why are we so concerned about the baby to be shifted?
It involves all the organs. We are concerned mainly about the respiratory system, respiratory distress. Then we are concerned about the CNS complications. Child may land up with anoxia, later prolonged cerebral palsy. One of the symptoms can present. Then the gastrointestinal symptoms can land up in necrotizing enterocolitis. Then various metabolic problems, hypocalcemia, hypothermia. So the
Even
list
if
is
the
so
baby
on.
survives the later delayed complications.
Cognitive and
Even
motor
if
impairment. Yes.
So preterm birth will involve immediate and long-term consequences also. And necrotizing enterocolitis sometimes presents after 2-3 months of birth.
Yes.
So whenever the baby has been in an ICU, you have to be careful. I mean, obviously the neonatologists do take care of it, but at the same time, since the patients are with us for a long time, they keep on coming back and asking us. So we also need to update them about
One more complication which is very commonly seen, if the baby survives, like baby is there for oxygen for many days, retinopathy of prematurity, and if we don't explain it to them, then they come back at the age of 9 months or a year that the vision is lost, then you are lost. So it has to be explained before discharging the patient baby from the nursery. Yes.
Yes, very true, very true. Okay, so now whatever has happened in her this pregnancy, any specific advice or any specific precautions would you suggest to her for her future pregnancies?
We have to look into the cause of premature labor. Is it a recurrent cause? What we should try to establish the cause. What would, if it is a imminent infection in this pregnancy, maybe that may not reoccur in the next pregnancy. But if it is a uterine anomaly, or it is a short cervix, or any prior cauterization, any surgery of the cervix has been done, then she can land up in a preterm labor. Definitely, even if there is no symptom, no cause established, one preterm labor, patient can definitely go into preterm labor in next pregnancy. So we have to tell her that she has to be in a good antenatal care with cervical assessment at 13 to 14 weeks, along with an early anomaly scan in the next pregnancy. If needed, cervix is small, or if there is a possibility that we can put in a prophylactic circlet, which is again a dilemma, or we can put her on progesterone from 16 weeks onward if there is, and we can follow her up.
Yeah, true. So for this, since it was her first pregnancy and she landed at a preterm where she has come with 3 centimeters dilatation. So cervical incompetence can one of the cause of it. Infection, of course, will be in a non-recurrent category. So 2 things we need to be very cautious about in the next pregnancy is prophylactic progesterones and cervical encerclage. So this again will be a topic of debate, and it's a complete topic. So it depends on your personal experience and whatever the ultrasound findings you get in her next pregnancy. So the prophylactic progesterones are equally effective. But yes, where there is a history of preterm or there is a history of incompetent os, then the application of cervical encerclage is what should be practiced for the future pregnancy. All right, so I think now Dr. Anshu will take over for the next case.
I can see our all vibrant panelists who came with the well prepared with all the questions. So it's my pleasure to start with the second case. First of all, I would like to thank Dr. Mandakini ma'am and their team to making me a part of, to just giving an opportunity to just moderate a panel. So now coming to the second case. Second case is Mrs. D, a 39-year-old woman, and she's IVF conception with a GDM presence to the labor and the delivery unit at 31 weeks gestation, with the complaint of sudden gush of fluid and the regular contraction occurring every 10 minutes for the past 1 hour. She has no significant medical history and is pregnant with her second child. So any guess what is the diagnosis of this patient?
Preterm PROM.
Okay. Anything else is added thing which we can see in this patient?
GDM is that?
Gestational diabetes.
Gestational diabetes and an IVF conception. But why this is an IVF conception? You have said that she is pregnant with a second child. So was the first normal conception and
is old, and her elder one is big. Second time she was not able to conceive, so she went for a IVF. So that's why this is a second IVF conception.
She is 39 years.
GDM
patient.
Ages.
So first was a normal full-term delivery.
First was a normal delivery.
Full-term delivery.
So this time she came with the key point in this particular case is pre-PROM with GDM. So now I would like to share their examination finding. On examination, her cervix is found to be 2 centimeter dilated, 30% effaced. Fetal monitoring indicates reassuring fetal heart rate on CTG. There are no signs of placental abruption, and she's experiencing a mild to moderate lower abdominal pain, and which is evident on a NST machine. So I would like to just go for a first question as a what is your diagnosis in this particular case, as I asked earlier also, but now what you will, after the clinical finding, what will be your diagnosis in this particular patient? Anyone?
Second gravida IVF conception, gestational diabetes with preterm PROM at 31 weeks of gestation.
Yes. So this is the diagnosis. And what are the appropriate steps in the initial assessment and management is in this particular patient?
We have to confirm whether it is really a preterm PROM. We have to confirm whether leaking is there or not, because if leaking is present and she is already diabetes, is it controlled on drugs, on diet, or on insulin?
She's on diet control.
Diet control, okay. Because since it is a prematurity, we need to give her a corticosteroid. But again, giving corticosteroid in a diabetic mother, though well controlled on diet, giving steroid will increase her sugar. So she needs admission, she needs an antibiotic cover, she needs a steroid cover, but under the cover of insulin with the regular sugar monitoring.
So basically in this patient, we have to keep two things in our mind. One thing is a diabetic, and the another thing is the role of steroid, the dilemma of the steroids in this particular patient, how and where. So very truly said, Dr. Anju. So the first thing that we have to confirm the diagnosis of this patient is very important, because the history of sudden gush of fluid is not always associated. We are seeing in everyday practice, it's not always associated with true PRM. So first of all, we have to establish the diagnosis and then proceed accordingly. So now the next question is, how will you proceed for the management? Suppose the patient is diagnosed with the true PRM patient and the same findings. So what will be your management plan in this particular patient?
Admit the patient.
Okay.
And then go for the investigations to assess whether infection has set in, and also for the blood sugar monitoring.
What are the basic investigations you would like to send in this particular patient?
CBC. First thing will be CBC to establish TLC, DLC. We have to see that. Then as high vaginal swab for infection, and blood sugar, urine.
And urine culture also. But very, very nicely said, Dr. Rachna, because high vaginal, there is the importance of high vaginal swab in this particular patient, because not only for the maternal point of view, for the fetal point of the baby point of view, in later part, once the baby will be delivered, this the vaginal infection will guide our neonatal unit also. So what are the things they can have to go for the baby, that particular baby? That is very, very important if the patient comes with the ruptured membrane. The second thing, what are the another and that investigation which we can send, and we can pick up the chorioamnitis little early than our the TLC counts. CRP. CRP is a one investigation we can send little early, and that used to be little raised rather than the total leukocyte count. So that can give you the idea about the chances of going towards the chorioamnitis little early. Although the patient comes with the PRM, but the membrane rupture, the counts are normal. But if the CRP is raised, that indicates there is some infection, pre-existing infection, which is there, and that can lead to the severity. So we can pick up little early by sending a CRP, which is the one investigation. Yes.
One point I would like to mention here is, though CRP is a little indirect or a non-specific test, but yes, a basic CRP you should always do at the admission along with the CBC. So as Dr. Anju mentioned, CBC is usually, the TLC count is usually not affected in the beginning. They start rising only as a reactionary to the infection when it starts increasing. And secondly, whenever you admit a patient, yes, of course, the pulse charting, the temperature charting is also very important. So
along with the clinical parameters, this is the one thing which you have to keep in your mind to just send. So later on, if the patient is not that going towards that chorioamnitis, features of chorioamnitis like raised temperature or the TLC counts is going gradually raised, so you can predict little early. So this is the one thing which we can do. So another thing. So how does the onset of regular contractions and PPRM at 31 weeks of gestation impact the management and potential outcomes in this particular patient? Suppose the patient came in with the history of the PRM. She is having regular contraction, and what is the specific thing we have to be keep in mind as a GDM IVF patient in this?
Sugar levels.
Yes, very true. So we have to take a baseline sugar level because we are going to definitely give steroids, but we should aware about what is the baseline sugar in this particular patient. Then only we can assess either her sugar was high or it is because of the effect of the steroids. So baseline sugar is must in this particular patient, and we have to go further. So now this patient is having all, as I said, having the regular uterine contraction, she is dilated also. So will the presence of GDM affect the management and the potential intervention during labor or delivery in this case?
Definitely, because GDM predisposes her to infection.
Yes.
Increased sugar level predisposes her to infection, and definitely if there is a sudden resurgence in sugar, this baby is predisposed to intrauterine death. So her sugar level has to be monitored very carefully, maybe every 2 hours, and if needed, an insulin cover has to be given.
Yes.
And an antibiotic cover has to be given to the patient, and her hydration has to be maintained. We have to look that way. If sugars are increasing, she doesn't land up in ketoacidosis. So it is a medical management altogether along with the labor management.
Yes, very true. So here we are not only bothering about the baby, we have to bother about mother as well, because she is a diabetic. We have to take care of her sugar level as well, but simultaneously we cannot sacrifice the dose of steroids. Definitely we have to give the steroids and monitor her sugar, and accordingly, if required, she will need a insulin as per her requirement.
Yeah, so in this case, since she is already 31 weeks, so probably strict sugar monitoring with insulin if required based on her sugar levels, and probably if we can pull through 48 hours without infection, then you can take a decision about the delivery.
Yes, the role of steroid is more because usually mothers,
48 hours will be enough. I think that not more than that. Then definitely infections may start.
Yes.
With GDM and rupture of membranes. Both factors are there.
But usually
with GDM, the maturity for the baby's lung is delayed.
Steroids are important in this case.
Keep in mind, because in a GDM the maturity happens little late, so we cannot sacrifice the dose of steroids. Definitely we have to give, but simultaneously we have to monitor the sugar, and accordingly we have to put a patient on insulin. So can we go for the expectant management or delivery? What is our
management? At
no
least
role of expectant management, only till the steroid cover is given.
Steroid. We have to wait for the steroid. 48 hours, we can definitely that much expectant we can give, not beyond that. That's what I think.
Very true. Because she's already 31 weeks. We already covered the things, and with the just expectant, there is no role once the membrane rupture, especially in a GDM where the chances of infection is very high. So for both mother and the baby's prognosis, it's not going to help anymore for the expectant management. It's all right. Now I just
So in this case, would you like to go ahead with the tocolytics, or you will just give steroid and expected management?
No, tocolytics, as we discussed in our previous case, till the time we have to achieve our the two.
Yes. 48 hours. So since she is not having any signs of infection, we can give tocolytics for at least 48 hours.
Contractions. That's why we have to give the tocolytics as well. So again, here, what would you like to choose your tocolytics in this particular patient? What will be the choice of your tocolytics?
Again, availability would be best, would be nifedipine here. Then sometimes, yes,
Duvedeline also,
yes.
Duvedeline also can be.
No,
yes.
Atosiban. It is very expensive and we don't get it.
Very frankly speaking, in our, as per literature and theoretically, we are discussing so much, but in since last 18 or 20 years of practice, I most of the times, 98% use Duvedeline, and it's effective and outcome is good. So
we have been using it, but I think nifedipine is also giving
Equally
very
effective. Yes,
equally
nifedipine also gives a good result.
Earlier,
The only
using Duvedeline, but now nifedipine I have started using, and I'm feeling very confident with nifedipine also. Equal results with the both of them.
Yeah, with nifedipine, there are two major
Duvedeline,
problems. One is tachycardia, which occurs with Duvedeline also, no doubt. But sometimes patients get very bad headache with nifedipine.
Yes.
That is
one of a common complaint. And the another thing, you will get a frequent phone off, not like equally like a isoxaprine group, this Duvedeline, but you will definitely get a phone call from your sister. The BP is going very, very less. So this is the two things clinically we are fixing. So because of that, in that platforms, although they are from a same group, but still, so Duvedeline equally helps. And why I am emphasizing on that, so recently there are so many researches on the Duvedeline group, because initially as our PG time, it was said like it's just like a rubbish, nothing going to help. But now, especially in the Indian scenario, in Indian females, because of the drug, the studies were done and they said it's equally effective and we can use the Duvedeline as per our guidelines.
I will use magnesium sulfate in this patient because she's less than 32 weeks as a neuroprotection, and it may also help as a procolytic.
Again, for the neuroprotection magnesium sulfate, there are two school of thoughts. One is saying you should use up to 29 weeks, 6 days only, means 30 weeks, up to 30 weeks. And the few are saying you can use up to 32 weeks. So the things are still not very much clarified, or not. It's not given like you have to use till 32 weeks, but there are two things are there. But yeah, definitely you can use. But as per neonatal team and then their guidelines, they are saying up to 30 weeks is more than enough for the neuroprotection point of view.
Yeah, according to the NICE guidelines, it is use of magnesium sulfate from 24 to 32 weeks. So there's no harm in using if the pregnancy is less than 32 weeks.
32 weeks. Yes, actually, I gone through all the other guidelines as somewhere they are saying 29 weeks, 6 is that.
Yes. So 30, less than 30 weeks should use for sure. 30 to 32 weeks, there is no harm. I mean, your patient is definitely under strict monitoring.
Yes.
Monitoring benefit.
Monitoring is must. So no, yes. Now you want to continue, Dr. Sanchita, with another?
Shall we? Yeah, it's what time? It's shall we go ahead with the third case or shall we conclude? Dr. Monica?
Go ahead. It is quite interesting and people are listening.
Okay.
I'm sorry, Dr. Anshu. I have to leave. I have an emergency call from the labor room. I'm really sorry. Thank you, madam, for giving me this opportunity. I would have loved to continue, but it is an emergency. I have to leave, madam.
No problem, ma'am. It's
okay. We'll miss you, Dr. Anju.
I would miss the so nicely be organized panel. I wanted to be part of it till the end, but she's just calling me that one of my patient is in preterm labor downstairs. So I have to Actually, I have to leave.
So, Dr. Mandakini, if we have any faculty still listening, they can also join in as a
Yeah,
panelist.
I will just request one of the attendee here, Anita. I'll just see who is there.
Yes, ma'am.
Please
Ma'am, you
carry
can be
on.
one of the panelists with us. You can give your inputs.
Yes. Okay. Okay, because I am just
Okay.
in another
Dr.
program.
Anshu, you can, Dr. Anshu, you stop sharing so that I can share my screen for the third case. Okay, so we
रश्मि आप पैनल में हो रश्मि
हाँ ठीक है
हाँ प्लीज
हाँ
मैं
बिल्कुल
दूसरे वेबिनार में 5 मिनट के लिए जाके आती हूँ
हाँ हाँ मैं हूँ इधर
हाँ so you please invite Rashmi also for wonderful discussion and Sanchita she's there.
Yes, ma'am. Dr. Rashmi, you're most welcome.
It's my
Dr.
pleasure.
Rashmi, we are from the same home society, Noida. So
and it's my pleasure
great
because
honor
both
to be.
of you are going very strong. Anshu and you both are doing
Thank you,
very
ma'am.
well.
All right. So there is another interesting case. This is a real case, I would say. She's still admitted under my care right now. So she's 35-year-old. She presented with labor pains at around 26 weeks of gestation with lower abdominal pain and vaginal bleeding. She had a bad obstetric history. This is her fourth pregnancy, and she does not have a live issue as of now. She is a diagnosed case of biconvate uterus. And yeah, she has come with regular uterine contractions every 5 minutes. On vaginal examination, the cervix was closed. There's slight vaginal bleeding, and ultrasound has confirmed to be a low-lying placenta. Her obstetric history first was a missed abortion at early gestation. No DNC was done. Then she underwent a cesarean section at 29 weeks. The baby was 1.2 kg. Baby was in the nursery for around 1.5 months. Was discharged. The baby developed necrotizing enterocolitis, was readmitted, was advised surgery. They transferred the baby to other center where the baby was operated. Then the sepsis developed and the baby did not survive. Then her third pregnancy, she had a miscarriage at 14 weeks. That time also she had a placenta previa, and she had torrential bleeding, and we had to give her 6 to 8 units of blood transfusion, and we had to terminate the pregnancy. We could not save her this third pregnancy also. So now what would be our line of treatment for her?
This third pregnancy.
This is a fourth pregnancy. This is a fourth pregnancy.
Third one is terminated vaginally.
Vaginally.
First thing is, I think it should be a conservative management for this pregnancy, because it's a bad obstetric history. So we should definitely go for conservative management. And she is not exactly in labor according to the vaginal findings and all.
I have to see the clinically whether her uterus
So
is
any maternal factor?
No, she is not diabetic. She is not hypertensive. She is no medical complication as of now.
Okay. So because there are two things, baby is, I think fetus is 26 weeks.
26
Slight bleeding is there, and marginal placenta, low-lying placenta.
Low-lying
It's
placenta.
not a central or something. So
No, it's not central.
So we'll go for conservative surgery, and we'll give progesterone definitely, but we'll give both the progesterones.
She is
vaginal.
already, ma'am, she is already on progesterone, right? Because she had a bad obstetric history. She had a history of preterm delivery. And one thing also, she had a biconvate uterus.
Yes.
She had
so she's already on progesterone. And in spite of being on progesterone, she developed preterm labor.
No, she is taking both vaginal and that, or only of intramuscular?
She is taking both.
She is taking both.
Weekly intramuscular and sustained.
Okay.
Like
So
we can
that is-
admit and put her on rest, and then we can start on tocolytics also. Now she needs tocolytics because she has developed pain. And for the baby, we should give corticosteroids.
But what is the
And
cause of severe abdominal pain in this patient?
She's having mild uterine contractions. She's having contractions. See, one point which we did not discuss in the first case, and about the precautions which we need to take for the next pregnancy. One is a uterine anomaly. So in her case, this biconate uterus per se is one of the cause of a preterm delivery. She had first at 29 weeks and now again at 26 weeks. Though the literature says that as the pregnancy advances, the duration of gestation can be increased, but we are not very sure whether this pregnancy was in the right horn or the left horn. So they may be an either horn. So sometimes one horn is more developed and you can carry on pregnancy to a better extent than as compared to the other uterine horn. So
definitely we'll go for tocolytics. So,
and here the situation is slightly tricky because she's having bleeding. So one of the contraindication for tocolysis is if there is any sign of placental separation. So we have to, before starting tocolytics, we have to be
low lying.
But ultrasound it is not there.
Placenta is low lying and there is no abruption that we can.
Abruptio is not there on ultrasound.
Placenta
So this bleeding will stop if tocolysis, because there is no option. If you will deliver her 26 weeks, it's too early. Then prematurity.
The baby is just 670 grams right now.
So it's better to,
yes.
And even bicornuate uterus, recently I have developed, I have delivered a bicornuate up to 34 weeks. You can just
sometimes, ma'am, bicornuate uterus is an incidental finding at the cesarean or
both of them.
So bicornuate, we have seen 3 kgs baby also delivering with bicornuate uterus. So sometimes it's just an incidental finding at the time of cesarean.
Maybe, definitely.
It's not always necessary the bicornuate uterus will go with the preterm delivery only. The main concern about this case, what is the cervical length? Here, I think Dr. Sanjita is going to emphasize on a cervical length in this particular patient as well.
So actually, this pregnancy, the cervical length, I mean, I think I have mixed this. I have written low placenta. Actually, this pregnancy, the placenta is not low. And in her 17th week scan, the cervical length was 0.5 millimeters. 5 millimeters, 0.5 centimeters. 0.5 centimeters at 17 week scan with the funneling. So we have put in a cervical stitch also. So you can skip that low placenta part. We have applied this stitch and now the cervical length is 1.9 centimeters with the stitch intact.
With the stitch, okay. And any signs of infection or anything?
Right now the CBC and CRP are fine. So
high vaginal swab. What about the high?
That is no growth, and this this is a real case which I am discussing right now. So this female, she was admitted 4 days back, and now today she has developed leaking.
Oh my God.
Gush of fluid, and it is grossly leaking now. So I mean, it is very difficult for us now because today also I have repeated her CBC and CRP. It is normal. I have not given her any tocolytic because now her pains have stopped. We have given a course of tocolytics. We have not yet given the steroid because when she was admitted, she was extremely 25 weeks. We don't give this thing. She will be completing 26 weeks tomorrow. So now I can think of giving her tocolytics. So again, one of the question was at what stage or what gestation we should think of giving tocolytics. If it is 24 weeks, should we give antenatal corticosteroids at 24, 25 weeks?
24, 26 weeks we give.
Yes.
Less than that, we don't give corticosteroids. That is not like, it's not a viability period. Like it's not viable. We don't take it.
If we talk about the age of viability,
It
When
starts
we
at
were doing PG, it was 28 weeks. Now it has come down to 24 weeks.
Wanted to emphasize,
So
Dr.
if we are giving magnesium sulfate at 24 to 32 weeks, I think we should give antenatal steroids also.
Yes, that ways it is. But normally we don't give below 26 weeks corticosteroids.
But now she is 26, so you can give, and maybe with single dose also.
Yeah,
And
any doses.
any dose you will.
And two doses, 24 hours apart. What Dr. Anshu Rena has to say?
I just wanted to share one of my patient recently delivered, I think 3 months back, and we come up with a good result. The same my follow-up patient, she leaked at 26 weeks, totally nil like her. So we were totally like lost, and it was a previous pregnancy, like with the follicular monitoring and the everything done. Then we, because she was 26 weeks, still we tried with the magnesium sulfate and all the dose of the corticosteroids given, and then we delivered her by C-section, and that baby survived. And the good thing about that baby didn't require any support throughout. She just born with a 670 grams, and she went home with a 1.75 kg, and she is doing well. So yeah, it's nothing like you cannot give. Although the viability is 28 weeks, but you can give 26 weeks. 2 babies we just taken care, that is at 26 weeks and 27 weeks. Recently also one baby is still under in NICU. She's just 26.
So at 26, so if the pregnancy is touching 26 weeks, we should give tocolytics, we should give antenatal corticosteroids, not less than 26 weeks. If it is 24 weeks, we have to wait and watch.
Yes. Once you will plan for a delivery, definitely you have to give a dose of steroids as well as neuroprotective.
So now, since she already had cervical stitch in C2, she had developed leaking. She's not having contractions. So we should continue with the stitch in C2, and we just keep on monitoring her till we see sign of infection.
Yeah.
Yes.
No, I don't think so. You only till you this you can give your cover, neuroprotection and steroids, and within 24 hours you just deliver.
At 26 weeks, ma'am, if she is not having any
But
pain,
then chorioamnionitis is a bigger problem for mother.
We can monitor it.
If the contractions are not there, you can wait.
No, weight is not the way. Pain is not a problem, but frank leaking is a problem, no?
No, but if Liker is okay. It's a frank leaking. Liker is still okay, then you can wait. You can give.
Yes.
So I think the decision
depends on you can keep on monitoring. The fetal monitoring should be there, and you can wait.
So our main decision, our main decision for delivery will be based on the signs of infection.
Yeah.
Yes. Signs of
yes, definitely.
Till about at least 28 weeks, at least till 28 weeks. Then we can again reevaluate if
there are infection, Liker is all right, baby is all right, can wait till 28.
Pregnancy up to 28 weeks.
Yes.
So many
at least we'll increase some prognosis. We will improve.
Yes, definitely.
But I don't think so. If today frank leaking is there, I don't think 2 weeks she will pull it.
Then she may.
नहीं खींचेगा तो कर लेंगे deliver. अगर
Ma'am, as per pediatrician, neonatologist, every day, single day
matters.
Every day matters. I have seen prolonging to 2 weeks with frank leaking also. They do.
Yes. So basically, our decision will be based on signs of infection. If she is showing any sign of chorioamnionitis, not for the baby, it is for the mother's sake that you have to take a decision. So the point is very clear. Timing of delivery, you can be conservative with her till there is no sign of chorioamnionitis. The moment you see any sign of fever, tachycardia, increased TLC, any sign, you have to take a decision for delivery. And you remove the stitch, and if the prognosis for the baby is poor, you can think of vaginal delivery. If not, then go ahead for the cesarean. And what antibiotic should be given in her case?
As per guideline,
Erythromycin is there.
we have to put the patient on erythromycin, but it's not. So we have to put
does not work. That's why I was not saying, because according to guidelines, ampicillin and erythromycin, but that does not work.
So not erythromycin, not at least not this augmentin, because it can cause necrotizing
fetal
enterocolitis.
Yes,
Not
not use the
Otherwise, you can cefotaxime or any third this thing cephalosporin you can give.
Yeah, but because there is a guideline saying even if you are practicing with your another antibiotic group, you should always add the erythromycin or azithromycin group. That used to be helpful in these kind of patients. So there is no
Azithromycin is better than
And
erythromycin.
antibiotic adding is never a problem, I think. You can always.
We have started Azi for her, azithromycin for her. That is almost since admission she's taking that. And since her TLC and CRP is fine, we can think of giving her cefotaxime if required. If she's
Now that she has started leaking, I think you should add it.
Any
Isn't
role
it?
of
You should add it.
anaerobes, metronidazole or anything, Dr. Anshu?
Although it nowadays the metronidazole is came in a group B category, so we can give there is, and especially once you reach that formation part time, that is already done, 19 weeks is over, so there is no harm in adding metronidazole at all. You can
also give local clindamycin also to this patient.
But metronidazole you can safely add now.
So we can wait for a vaginal swab, which we have.
Vaginal swab.
So if swab doesn't show, hold on to metro. I think based on the high vaginal swab result, we can think of starting another antibiotic.
Clindamycin, yes.
All right. So I think
now I think already
if you can take over for the final take home message and the guidelines.
So after a long
can I add a sentence, ma'am, if you feel like?
Yes.
Dr. Manapal. Ma'am, the role of prebiotics has not been discussed.
Yes, ma'am.
Yes.
Most welcome, ma'am.
Yes.
The role of prebiotics. Prebiotics definitely help in prolonging, ma'am. And secondly, we should also search in for dental infections, because that is also a very important source for preterm labor, ma'am.
Yes. Very good.
So we should add a probiotic also for her.
The studies are still going on a probiotics. So many studies come up with the role of probiotics. So definitely we started using probiotics in our patients, even in an antenatal period as a prophylactic also in so many high-risk patients we are using. So, but
I think it's a good idea. The probiotic are not going to cause any harm. Secondly, since the patient is slightly restricted mobility, so it will help her in digestion as well.
Yes. So we can use, but the further research is definitely needed, and the guidelines have to enter in this protocol. So now, after a long discussion, I would like to just conclude the things with the key take-home messages. So first thing, to prevent preterm labor, that is must. The prevention, we all know the prevention is better than cure. So by doing the early screening and the diagnosis, which we discussed in our multiple cases, our aim should be to arrest the preterm labor if not contraindicated in that individual patient. Appropriate management according to an individual case is must. It's not a one for all law. It's not for one law for everyone. So we have to think in with the all according to the patient requirement. Definitely the use of IV magnesium sulfate for the neuroprotection of the baby, and that is to be done between 24 to up to 32 weeks. Few that studies say 29-30 weeks, and the few as we discussed earlier. The maternal antenatal corticosteroids that to be given between 23 weeks to 33 weeks, 6 days. So as few studies, as we are in dilemma, we are saying, should we give 26 weeks? But the studies says it can be given from starting from the 23 weeks to up to 36, 34 weeks. Even the few studies came with the so it to be given at 36 weeks even. But again, there is a two school of thoughts. So we have to stick with the guidelines. What the guidelines say, it's up to 34 weeks we have in case of established preterm labor. Definitely the use of antibiotic is must to reduce the chorioamnitis, prolong the latency period, and to improve the neonatal outcomes. So, because the tocolytics has been found to be useful in delaying the preterm labor, only isoxsuprine and the atoxibin are approved by the CDSCO, and that is the Society for the Drug. And the management of preterm labor in Indian context, that is isoxsuprine, which I was emphasizing in my discussion, should be considered as it is economical and proven to be efficacious, especially in the Indian scenario. So that is as per our FOXI guidelines, we can use the isoxsuprine. There has been because the drug control general is proven the drug for the especially in
light work along.
And we must consider the prophylactic cervical surplus between 16 to 24 weeks if there is a history of the recurrent pregnancy loss because of the cervical incompetence, or it varies from patient to patient, has a history of bad obstetrical history, definitely after excluding the all contraindication. The role of progesterone is definitely there, as we discussed and discussed by even Dr. Mandakini, ma'am. So the cervical length is shorter and the progesterone to be given injectable and the oral progesterone is advisable as per our guidelines. And the most important thing about all these discussion is the counseling of a patient and the patient relatives regarding the premature delivery and the need of NICU care is must. So once the patient comes, repeatedly Dr. Sanchita was telling, you have to discuss with the relative and one not only by the obstetrician, preferably if you are living with the NICU setup, your neonatologist also should discuss the patient and the baby outcome and the need of NICU care. So if you will, the baby and the mother will go for a delivery, how much they stay and what are the complication related as per our medical legal point of view. So prefer in utero transfer in absence of NICU facilities, as discussed by us earlier. If the patient condition allows, preferably if you don't have a NICU facility, you should transfer the patient in utero. The outcome used to be better than sending a patient after delivery. The route of delivery varies upon patient's condition and the gestational week. So again, this is the one of the controversial question. It's not always mandatory to go for C-section in preterm delivery, as guidelines say. It depends upon the patient's conditions and the gestational age and varies from patient to patient. C-section is not indicated for all the patient. That is the must masses to be taken by all. So it's not indicated by any guidelines. So last but not least, I just wanted to say that creating a world of healthy beginnings, that is by us only to prevent a preterm birth. And it's a right of all the mothers. So we have to take care, and the must thing we have to know about, we have to prevent, and we are the one who can prevent. So thank you all of you, all that learned panelists, and they participated very enthusiastically and they well read. Thank you all of you. And once again, thank you, Dr. Mandakini ma'am, and for making.
Thank you to the moderators also. Very nice selection of cases and very nice discussion conducted.
Please stop sharing, Anshu.
Ma'am, for
we can see each other.
Both the
Thank you
moderators and Mandakini, thank you so much for involving me in this important panel discussion. Thank you
And
so
please
much.
put the video on so that we can take a good shot, and it will go in the archives for the UP, Gyanganga UP. Can you put the video on? Who all are there? Yeah, I'm taking a shot, nice shot. Yeah. So I think
it was a very, very good experience, Dr. Mandakini. Your series are going, it's a hit. It's a 100 crore earning now
And
in terms of knowledge.
all
So
the
it has
best.
joined the 100 crore club.
And best thing is this series has repeat
The
value
name
also.
is name only suggests it's really Gyanganga.
Yeah, and it goes very well with the UP. I was telling Meera madam, Kanpur se Ganga behti hai, udhar UP se Ganga behti hai. I said it is synonym with the UP.
हमारे घर में मैडम हमारे नोएडा में हमारे घर में पीने का पानी भी गंगा से आता है नहाने का
Ganga supply,
क्या बात
yes.
है, क्या बात है। भाई आप लोग तो बहुत लकी लोग हो। हमारे मुंबई का देखो,
गाजियाबाद में भी गंगा
मुंबई का
वाटर।
देखो, हमारा छन छन क्या था समुद्र से। आप पीछे समुद्र देख रहे हो ना, वो मेरे घर के पास में समुद्र छन छन क्या था। So anyway, nice यार, it was very light moments. First of all, I'd like to thank our chief guest, Usha Sharma madam. I'm concluding, officially I'm concluding. Usha Sharma madam, wonderful person. जब भी आप उनको बुलाओ, she is ready and always shows her trophy of the Vidya Bhushan award which I have given her. So I think she is a very generous lady, and she has in front of everybody said, we are with you, Mandakini, no problem, because you are the, I mean, I should not say on the national platform, but you know, they like me so much and my work also, and academic work also. Similarly for the Meera madam, what can I say? Both the legends and everybody is on the 1 minute. एक सेकंड वो कुछ फोन आ रहा है. Everybody is on the same platform, and I want to thank both the panelists, Anshu and Sanchita. Great job, beautiful cases. Actually, I wanted to, you said you want to stop. I said nobody wants, because I'm getting messages. Please keep on. They both are doing such a wonderful job, and some are very good cases. And you have given a wonderful message. When should the corticosteroids be given? When should be counseling of the patient? अपन अकेले patient को कैसे कहेंगे? We have to have a family. We have to have a pediatrician. Yesterday there was a seminar on medical legal, this thing, counseling only. Counseling is I think this is the game changer, because you only tell the patient what exactly, and then shifting to the higher level, that also is very, very important. And most importantly, I also mentioned about the AI. So I think in the days to come, the AI is going to be there for the depicting, or actually, knowing the exactly how the labor will be taken. And preterm labor, they are going to, give us the correct diagnosis when to deliver the patient. So I think that will be again a little advanced, of course, but I gave a oration very recently. That's how I am very fond of that AI. And panelists, Savita, and everyone here, Dr. Rachana, Dr. Alka Sethi, and Meera madam, already I said.
Anju was there, she's left.
Who was there? Anshu?
Dr. Anju.
Anju was there. And Kanchan, everybody did a fabulous job. And I think we look forward many such. See, every month we are, Sanchita, we are having this. So ask your juniors or people to join, because one was gestational trophoblastic tumor. So Northeast Society told me, madam, we are having more incidences of GTN. So we took that. Then rising rate of cesarean section, Telangana, 60-80% cesarean section. And Anshu, one more thing which I liked in your concluding remark is there is no need for cesarean section, which is emphatically told, because now we are under the scan of the government. In the Maharashtra also, we got a GR. Foxy also got a letter from the government that please explain. And now in a coming months, I think we are supposed to give our data of cesarean section. So you please self-audit, give correct indications to your juniors or even in your institute. This is one of the indication that cesarean section is not, advised in this preterm birth. So that is a very correct message which you have given.
So we have to check the data every month.
Yeah.
How many families you are conducting?
Yeah, Savita, yeah, आपके यूपी में शुरू हो गया क्या data you are giving?
We have to send.
Yeah, हमारे यहाँ भी
Hospitals are
महाराष्ट्र में शुरू नहीं हुआ है. Yeah, so very good. So I think with all in all, it has become a very hit program. बाहर हमारे total registrations are 4,500, and the live also are there. So I think we have done great job of spreading the knowledge, and we took a very good subject, and lot of research, and I think you studied a lot. Anshu, तुमने बहुत study किया. Anshu और Sanchita, very nice. So with the hope that you people are there for me, and I'm also there for you always.
100%,
Always, ma'am.
Thank you very much.
100% we are with you.
And I want to become a leader of masses because already I'm the leader of masses, which our Veera madam, Chandravati madam, and Usha Sharma and our.
Your lovable nature makes you the leader of masses.
Thank you. This is sincere effort. I'm like this since my childhood.
You connect with everyone immediately.
Yes, madam, बचपन से ऐसे मतलब मैं हंसते हुए पैदा हुई थी. मुझे किसी ने कहा you are always smiling. I said no, I was not
आपको
crying when I
pediatrician ने
was
रुलाया
born.
नहीं? Pediatrician ने रुलाया नहीं आपको?
नहीं, अभी रुला रहे हैं ना. अभी कोशिश कर रहे हैं, पर मैं तो बहुत पक्की हूँ. Plus lot of experience in Mantralaya at every level, which is coming very handy. I'm telling you because why I can connect to the people, and also my husband, I must tell on the national platform, he is a senior IAS officer. And अगर कुछ नहीं हुआ तो मैं मेरे husband को बोलती हूँ प्लीज हमें हेल्प कर दीजिए, तो ही जॉइंस मी इन हेल्पिंग. पासपोर्ट की सिग्नेचर हो या ये हो या किसी की मशीन छुड़ाना, ही टॉक्स टू द कमिश्नर, एंड दैट आल्सो मेक्स अ डिफरेंस. सो आई थिंक ऑल एंड ऑल लेट मी बी यूजफुल फॉर एवरीवन. एंड अभी 1 महीना बहुत भारी है, but I think I will come through.
You will definitely, ma'am.
And keep in touch. और आप लोग मेरे लिए क्या कर सकते हैं वो अपन प्राइवेट में बात करेंगे, not on the national platform. So please phone me after this, okay? So Rashmi, my younger sister, thank you everyone. And good night. And Monica, last word from Monica.
Ma'am, you have already thanked everybody. I would like to.
We all must thank Monica. Great support. She does everything for me, from calling. I think you must have been troubled by her so many times, calling so many times. Everything she does for all my Gyanganga.
Not troubled, helped by her.
So Monica, thank you.
Monica, you have done a fabulous job. Dr. Monica, you have done a fabulous job. And working behind the scene is the most important thing to coordinate with so many faculties and get things set on time. So it was a great experience working with you.
Month after month she's doing. Whenever I told her I'm printing your photograph, she said, no madam, please don't print. It is not required. I have not seen such a person selfless. Monica, thank you very much for everything. And Amit, Amit for your digital support. And everything for doing. At the 11th hour he came into the picture on conference, but I think he also did a good job. And thank you very much, and good night for today.
Good
and
night.
be in touch. Be in touch.
Thank you everyone for your gracious presence, and keep supporting madam. And please answer to my calls whenever I call you. Thank you so much.
One last message I want to give everyone: always consider the merit of the person who has done since last 40 years or 30 years. Don't go by one day visiting, traveling, showing up. Don't go by that. That is my sincere for everybody. Maybe it is vice president. Maybe
बहुत
it is.
सही point बोला मैम आपने, बहुत सही point बोला. The merit should be from the work, not from just the face presentation.
Second thing, we should not be showing off. We should be very ethical. Somebody asked me, I am telling on the national platform. Somebody asked me, madam, ये gift भेज रहे आप बेटे, मैंने जिंदगी में किसी से gift लिया नहीं, किसी को गिफ्ट दिया नहीं. जिनको देना है वो मुझे मेरे प्योर मेरिट पे देंगे, एक बात है. और एमडी गायनेकोलॉजी इतने चीप नहीं है कि आपने कुछ 100 रुपए का मग्गा भेज दिया और उनसे बिक गए. ऐसा अगर हुआ तो मैं तो फिर तो दुनिया रसातल में चली जाएगी. No, somebody asked me really when the chairperson and the presidents of the society were given some gifts by some people, I don't know. Unethical.
I also got madam.
No. I want you to choose an ethical person. Second thing, approachable person in real sense. Don't go by. I tell all the people. Day before I told you that I got PCP entity registration, she was declined by the authorities, all authorities, even including doctors. I went, I said, what is wrong? Huh? She is shifting the hospital. Why are you not giving? Within 4 days, she got the registration. That is what I don't want to boast, but that is the work which we are supposed to do. So all the younger people, everybody, I said, don't go by the performance of 2 days. I'm going here, I'm going there. No, it's not like, it's
All the members,
continuous work, approach, whatever organization I have, we have, where there, suppose I was an IFMB president, you ask any Delhi people from Ashok Khurana, how much I helped them. DCBNDT, this thing, Ashok Khurana, Sachdev, Rahul Sachdev, his machine was sealed. I was the person who actually de-sealed his machine. Nobody knows. But so much work we are doing. So that is how a lot of goodwill is there. So go by the merit, go by the seniority, go by the person who can do something good to the obstetrician, and you can आधी रात को फोन करेंगे, मैडम मेरे साथ ये प्रॉब्लम है, तो I will be there. बस ऐसे व्यक्ति को अपोर्ट देना, यानी कि मेरे को वोट देना प्लीज.
और any function should be able to call you midnight.
Yes, no, thank you very much. Just joking, but anyway. So and give this message, Sanchita. It is you are a social person. You are not only obstetrician. किसी का भी कुछ भी सुन लिया तो नहीं. This should be going your message to everyone.
Everyone, yes, ma'am.
Society में
You
अगर
have
आप
a
अगर
leadership
आपसे-
quality. Leadership is not, just showing. जैसे नेता लोग इलेक्शन के पहले ही शक्ल दिखाते हैं, उसके बाद 5 साल गायब. It should not be like that.
दूसरा क्या है कि दूसरा मैंने ऑपरेट किया, ओके मैंने ये किया वो क्यों, पर तुमने उस आदमी को सामने के एक मेंबर के साथ क्या किया, उसको कुछ किया, उसको कुछ हेल्प की, उसका कुछ हुआ नहीं. सो वी शुड बी नोइंग ऑल दिस थिंग, डिसाइडिंग. और जूनियर्स को सबको बोलो कि डोंट गेट अफेक्टेड बाय ग्लैमर, सुपरफिशियलिटी. हाँ, अगर आपको दिल से चाहते हो तो ठीक है. सो प्लीज, ओके. हम तुम सारे यंग लोगों के ऊपर, मैं ये सविता, सब यंग लोगों के ऊपर ये सब छोड़ रही हो जिम्मेदारी. चलो, ओके, बाय बाय, गुड नाइट.
Okay, good night. Thank you, ma'am. Thank you for a big opportunity. Thank you, everyone. It was great learning.
Dr. Sanchita and Dr.
चला मोनिका, मी जाते आता.
Thank you, Monica.